pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Before everyone sits, if we can have a moment of silence for Earl Evans. He was one of the founding executive directors of the Remo region. My kids used to know him as Mr. Remo. He had been around for years, and unfortunately he died this past week at 89. Okay, thank you. If everybody would be seated. If we can have approval of the previous meeting's minutes, if somebody wants to make a motion for that. So moved. Thank you. Second? All in favor? Raise your hands. Well, that wasn't overly enthusiastic. Anybody opposed? Okay, any abstentions? It passes with a minor majority. All right, Ryan, are you ready for your report? You're next up.
Do you want to do roll call first, Dr. Doynow?
Okay, we can do roll call first, sure, why not? I was hoping to avoid that, but go ahead.
Dr. Bart? Dr. Berkowitz? Here. Dr. Berry? Dr. Bombard?
Here.
Dr. Cooper?
Here.
Dr. Cushman?
Cushman here.
Dr. Daly?
Daly here.
Dr. Doynow? Here. Dr. Gomez? Dr. Isaacs?
Isaac's here.
Dr. Kugler? Here. Dr. Lynch? Dr. Markowitz? Dr. Maynard? Dr. Marshall? Here. Dr. Murphy? Dr. Olson?
Olson here.
Dr. Talbot? Dr. Walters?
Walters here.
Dr. Wislinski? And Dr. Winslow?
Winslow here.
Oren Barzilay? Aidan O'Connor? Mark Philippi? Marianne Portoro? Dr. Raybridge? Mike McAvoy?
McAvoy here.
Steve Kroll?
Present.
And John Washko? How many? 13. We have quorum.
Excellent. Ryan, are you up?
I'm up. Chief Major, if you can come up as well. That's not just so you can pay attention. I have one thing in our report that I think you're best to speak on. All right, good morning, everyone, and welcome. Thank you for joining us today. I'm going to try and get through a couple of things here in our report. On the operations side within the Bureau, we are moving forward on surveillance and investigations. I know many of you have seen us at your local agencies as we continue to do our full service inspections and getting back on target. Just a reminder, those are on target to be about every 2 years. So the goal is that we'll be there every 2 years. For our core sponsors as well, and we'll get into in education, those site visits are also going to start back up again as we continue to add some additional staff on that side. So we've had some questions on that as well. So reminder, when we are there, a reminder for all of our EMS agencies, all the paperwork needs to go in through the portal. We've really moved towards paperless submissions to the point where we're even starting to return paper that shows up in our office. So if you do start to send things in via paper, there are times now where we're going to start sending it back to you and say, please submit this electronically. We tried the pathway of just saying, we'll send you a nice note, don't send it to us this way again the next time. It doesn't seem to be as effective as maybe returning the paperwork that needs to be done. So just a reminder, almost everything comes in electronically now. So there's something new, and this is what I've asked Chief Major to come up with us. We have started for our full service inspections an EMS self-assessment survey. And this is something we're happy to share the link so that everybody here can see it, or we can put it up as a PDF or share it that way. But there's an EMS self-assessment, and in all fairness, this actually came from another state who was trying to improve EMS sustainability and foster good conversations and things like that. And these EMS assessments are sent out when a full service inspection is happening at an agency. And the goal of it is actually really just to foster good conversations, both while the investigator is there, but as well as within that agency, to recognize what is, how the agency is doing, what they're focused on, and maybe some opportunities for the future on what to focus on in the future. So the reason why I asked Chief Major to step up and talk about this a little bit is there's a number of these things that talk about quality assurance and talks about medical directors and talks about medical director involvement, at the agencies. So I don't want it to come as a surprise to anybody on here or any of the colleagues that you're working or your REMACs. Hopefully you'll go back and share this with them as well, related to, well, what is this survey? I never heard anything. Who's asking the question? All these things aren't necessarily related to a regulatory obligation of, we're going to come in and say, oh, well, they didn't do this, or there's going to get an SOD. This is more about improving a system, strengthening a system, and fostering positive conversations. So with that, I'm going to pass to Chief Major a little bit about the history of where this survey came from, what it touches on, and where some of the results are going to.
Thank you, Director. My name's Ed Major. I'm from the Western branch. I'm the branch chief. You want me to say my name? Got that right. The survey actually came from the state of Michigan, and there was a couple others that we had looked at. And the coordination from an EMS sustainability standpoint, organization, internally from the processes of medical direction, what the recruitment and retention standards were, what the community involvement was, all sorts of activities related to the board of directors makeup, what the strengths, weaknesses, opportunities for improvement are, sort of a self-assessment from the perspective of EMS sustainability, funding, agency capability, looking at the quality of patient care and evaluating their futuristic objectives related to equipment and the ability to, are they looking at regionalization and some other quality components that are in this particular survey. So far, we've got about 50 to 60 responses back, and some of the information that we've got is pretty eye-opening related to not only medical director involvement and system improvement and what is identified as strengths. And we're looking at this from the perspective of, we're going to share this data. We don't have enough to quantify and to really give a quality assessment of what the individual responses are. But the method that we're using is Forms. It's Microsoft Forms. So it does break the data down and gives us graphs and some capabilities to sort of evaluate the responses so that we can sort of quantify it, look at opportunities for benchmarking. And our objective will be to share that data and get some real quality initiatives that are going, because it goes in conjunction with EMS sustainability, quality metrics, and also other components related to not only the medical director involvement, but what activities individuals are doing to strengthen recruitment and retention, which is really a big push to this too. So I could talk further, but I think that those are really the highlights, Director, of that. And we're going to, I'll get the link up. We will share it with the EMS agency briefing. We'll get that link up, and I think we could email it out with the correspondence here, if that's okay. Anything else you want me to say? Thank you.
Any questions? All right, terrific. Thank you so much, sir. Again, I think you'll start to see possibly some questions coming from your agencies, so we felt it was really important for each of you as the medical directors to understand that. So continuing on the operations side, like I said, the inspections are out there. One of the big things that we're finding is the way that the oxygen tanks are secured, both portables and the main tanks, are not in a fashion. They're either not using the straps correctly, or they're not using correct straps. So please make sure, if you are involved in an agency, to make sure that they're securing that appropriately for the safety of everybody involved. On the administration side, we continue to finalize some contracts. Big one on this one for your REMSCOs, your REMACs, your program agencies. Please make sure that when they submit their invoices, that we can spend the money, that they're submitting everything appropriately and on time. There's a new pilot program. You heard about 4 of them at the last meeting, but there's one additional one that's being included this time, which is the new recruitment and retention pilot program that came from feedback from the last meeting. And so what this program allows for, and the policy statement should be up by the end of this week, if not already, but what this policy allows for is for people who became an EMT, paid for themselves to go become an EMT, for them to work for an agency for a year and to be eligible for reimbursement for the course that they took. So the reason for this and the feedback that we got is we do a lot of programs where people are becoming EMTs, but then they never work on a truck. We are trying to say, okay, well, the people who took the initiative to get the training ahead of time and maybe paid for it, now they worked on a truck for a year, can they get paid back for it? I'm seeing a nod coming from Shauna over here, that gives them another opportunity. So this is another great opportunity to make sure to let your agencies know about a way to get back to one of the members. The agency does have to submit. The provider can't submit themselves, so the agency is submitting for that reimbursement. On the education side, a lot of stuff going on in education. We're really excited to have Kevin Lynch join as one of our newest unit chiefs in the education branch. He is out of the Marrow office. Kevin's a paramedic and an ALS CIC. He is currently dealing with all reciprocity applications and PSI issues. I know there's no PSI issues, so he's very slow on that part. But no, he's anything on that side, so you'll see communications coming from him. We have 2 new administrative support staff coming starting tomorrow out of the Albany office, so we're excited about that. Hopefully some of the timelines and things will be reduced in what we're able to get process out there. We also just received information that we are going to be able to post for John McMillan's backfill, so we'll have another grade 18 unit chief that will be posted in the near future that will be based out of, I believe, the central office, but I'm waiting on final confirmation. The paramedic or the online testing with PSI, there's been a slight cost increase. It has moved from $28 to $31, and that was effective September 1st. If you had vouchers or anything prior to that date, or you scheduled prior to that date, it won't affect your change and your vouchers should still work. If you have any problems with any of that, you can reach out to Kevin Lynch and he'll be happy to help you on that side to coordinate that side. We know there's been some issues with PSI, with testing. We know that there's been some issues on scheduling and things of that nature. We're looking at about 1,000 complaints a year related to that, when we test anywhere between 20 and 25,000 tests a year. So we're, in the ballpark, we're somewhere around that 5%. We want to make sure, though, that we are capturing all the issues that are happening. We think there's a series of issues that might be happening that we're not told about. So please, if you do have an issue with testing, you get to a site, they tell you that they can't test or whatever that might be, please make sure to let us know, put in a communication so that we can track that, even if it's been resolved already. So thank you for that side and letting us know. We have a large amount of student exams, so just in finding exams, so sometimes there's some issues with the upload. So exam results coming in, if for any reason that the exam results come in and you don't see it up on Health Commerce site, or you haven't gotten the communication on it, please make sure again to reach out. We process those, I think 2 to 3 times a week right now. So, realistically, you shouldn't be longer than 7 to 10 days after you've taken your exam for that to be showing up and to be on our system and to be on the Health Commerce system. If anybody is having issues related to any of these things, related to testing, they can reach out to us at ems.testingissues@health.ny.gov, and we're happy to take a look into those. There's, again, in the transparency side, and one of the things we've heard is, well, it took me a really long time to get a duplicate card request, or it took me a really long time to hear back about my core sponsors. So we have started something new. On the Bureau website, if you click on EMS forms and you click on either of the EMS education pages, drop-downs, it will show you a chart, and the chart shows the function of education, the average time that we think it takes to process, and what our current processing times are. And so we know we're ahead on certain processes, we know we're behind on certain processes from our averages, but that is available to everyone now. Please take a look at the date on the bottom. It'll show you when it was last updated. Our goal is to keep this, every 2 to 4 weeks, we'll update that chart. Or if there's something that's really an outlier, we'll update that chart. But you can give this to your students, you can give this to your agency leaders, your course sponsors, your CSEs, so that they know when to expect to hear something. So if something on there says average processing time is 2 weeks, and it's actually at week 3 or 4 for you, that's the time to reach out to us. If on there says average processing time is, or current processing time is 6 weeks, and you're at 3 weeks, understand it's still going to take us a little bit longer to get there. Any questions on educations or operations? Yes.
Olson, could you just reiterate, I missed where that website or web page was to look at processing times?
Sure. So if you go to the Bureau of EMS webpage, on the left-hand side, second button down, it says EMS Forms. And then in the EMS Forms page, there's a drop-down. If you go to Education and Certification or the other education button, that chart will be there on both of those.
Okay.
And then below those are all the forms to submit your stuff. Any other questions on education or operations? Wonderful. So there was a lively discussion yesterday about NEMSIS data and 3.5 and what the process will be. We talked about reducing some of the standards until 3.5 was initiated. I think the outcome, and I'm going to look towards Peter on this one to get a nod, the outcome is most likely going to be we're going to move towards 3.5. That standard will be released in the early part of November, and then agencies will be able to transition to 3.5 on the standard that's released between January and July of 2024. So no later than July of 2024, but preferably closer to January if possible. This is really beneficial for your providers. This reduces the number of mandatory fields. This makes it to where, I don't want to say it's easier to chart, but that they can chart in a manner hopefully that doesn't take as long. I will tell you personally, as I ride the truck, this summer, Peter got a series of text messages at all sorts of hours when I was frustrated writing my chart. And so we are working to reduce those frustrations and to ease into, a new charting pathway. I know there's been some discussions from the working group who works on these standards to also have them really kind of refresh and look at this from a new way. There were a lot of standards. Just for those who don't know, there were close to 900 standards or requirements in the current, or the old standards. The new one will be probably close to 250. So big reduction in mandatory fields. STAC, our next meeting is the second week in October for anybody who would like to join, and the 405 regulations had an emergency regulatory change in order to allow us to go to the new ACS Gray Book standards, and that just went into effect last week. EMS for Children, our next EMS for Children's meeting is in December here at the Hilton Garden Inn. They are working on the pediatric education group, is working on producing some videos and some education and working on some protocol recommendations. There's a ped stroke group that's gathering data related to ped strokes, and discussions is further coming. The grant had some carryover funds, so we have some additional projects that we'll be working on. Excited about that part. We have started on the new Ready for Children ED PEC recognition program. So this is a PEC program for emergency departments, so slightly different than the PEC program that's for EMS agencies. We have a little bit of sad news, is one of our EMSC members is departing us. Jacob in the front, wave Jacob, sitting up there. He has been a tremendous part of the Bureau. He is taking a fabulous new job, but we're sad to see him leave. So hopefully we'll be working on backfilling his position, who helps us with a lot of data analysis and data that comes in. The EMS for Children's program manager, Amy Eisenhower, is actually working right now on the Safe Transport Pediatric Testing Standards and is actually at an EMS for Children's conference right now. That's why she's not here today. We're excited about the Vital Signs PEDS classes that are being offered for safe transport, de-escalation, as well as disaster planning. And we also are continuing on our PEDS focus on Vital Signs Academy Online. Speaking of Vital Signs is October 18th to 22nd in Syracuse, New York. Registrations are going up and increasing and really excited about that. Hopefully going to start to see some pre-COVID numbers there. The hotel block closes soon. I don't know when soon is, but I know it closes soon. So if you are joining us there, please get online, go onto our website, and make sure to book your hotel sooner than later. Sorry, just catching up here on things. The vehicle and equipment regs. So these are the regs that are related to things that are going here. We were hoping to have an emergency reg packet presented to SEMSCO while we were here in order to push forward many of the things that were in place or looking to be in place because they were in place for Executive Order 4 and now they are no longer. Unfortunately, timing did not allow, although I think we're really close to finish line, so much so that there may be an emergency meeting there may be a short SEMSCO meeting between now and the December meeting to discuss, review, and approve those emergency regs if they do come through the approval process. We'll obviously make sure to keep everybody aware of if that's happening and when it's happening, if that does occur. The equipment regs are in the final process to go out to public comment, so they will go directly out to public comment because they are not under an emergency process. When those go out to public comment, we encourage everybody to take a look at them and also to comment both in the positive or any areas of concerns. We encourage you to do that one. And just a giant thanks to both the Education Committee and the Safety Committee for helping put those together. The Rural Health Task Force meets tomorrow. The Rural Health Ambulance Task Force meets tomorrow. I know some of our members are around this room. There is a Rural Health Ambulance Task Force survey that is out right now. It's available on the EMS forms page. Drop down to EMS provider surveys, and please feel free to fill that one out. That is based on recommendations that they're working on, what they think will be some of the things to really help the rural health side of things. We ask everybody to please take the time, take a look at it, and provide your feedback. In addition, on that EMS forms page, there's been a lot of surveys lately. So we've sent out a number of surveys. We tried to put those all into one place. That one place is now on the EMS forms page. So on the EMS forms page, under EMS provider surveys and feedback, there are currently 4 surveys that are open. We'd love everybody in this room to spend some time filling those out. Each are probably in the ballpark of 8 to 12 minutes to complete. But it allows so many of these working groups that are so active and, under Chairman McAvoy and the work that's being done by the SEMAC and SEMSCO and all the working groups, it really allows all providers to have say in this. So there's one out there on diversity, there's currently one out there on rural health, there's one out there on feedback from Part S. Please take a few minutes and take a look at this. This is how your voice is heard. Last but not least, we're excited on some new staff members. We mentioned Kevin before, who's joined us in education. We have a new staff member in vital signs, very excited about that part. We have Jacob, who is unfortunately leaving us, but for good things. Gina, who was our policy fellow before, is our newest district chief investigator. Very excited on that. She'll be in the emergency preparedness and response side of things. And in addition, we're excited to report that the Bureau is growing. When I first got here, we were just in the mid-30s or so. We are now north of 55 staff in our Bureau, and we are charted over the next 12 months or so to add probably between 20 and 25 positions to the Bureau. It does come with some added responsibilities, duties, and assignments, so they're not all just things that will help us to support our current functions. So there's some new ones, but we're excited to see the growth. We're excited to see the focus on EMS and things in that. And we're excited to be able to provide additional resources to the SEMAC and the SEMSCO to be able to carry out the functions that each of you are doing. So that is the end of our report. Happy to take any comments, questions, or concerns, and thank you for everything.
Okay, any questions for Ryan? All right, moving along. Dr. Marshall?
Good afternoon, everybody. Well, almost afternoon, sorry. Still got a couple of minutes. So medical standards met this morning, and we have 2 action items to bring forward. So the first one is the collaborative ALS protocol update and changes. And they did a lot of work, so I'd like to thank Dr. Cushman and everybody who participated. They looked at the protocols, they simplified language, reduced inconsistencies, and made it more readable without actually changing the medicine. So a couple of things, and everybody should be able to have seen the version 24 protocol change log, which I would also like to thank them for putting together, because this makes it very easy to see what changes were made. Two things came out of the discussion. One is the anaphylaxis protocol was changed to allergic reaction and anaphylaxis, which would enable ALS practitioners to administer Benadryl or steroids to a patient who was not in anaphylaxis. And the second item that came up that was discussed was that they also looked at scope of practice and removed any inconsistencies, and the one that was removed was CFR administering oral glucose, and that was removed. There were also some wordsmithing that made it more readable, and this comes forward as a seconded motion, and it is protocol change, so it will require a roll call vote.
Any questions for Dr. Marshall? Okay, none seen. Val, if we can have a roll call vote?
Dr. Berkowitz,
Berkowitz, yes.
Dr. Bombard,
Bombard, yes.
Dr. Cooper,
Cooper, yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly,
Daly, yes.
Dr. Doynow,
Dr. Doynow, yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Dr. Kugler, yes.
Dr. Markowitz, Dr. Marshall,
Dr. Marshall, yes.
Dr. Olson,
Olson, yes.
Dr. Walters,
Walters, yes.
Dr. Winslow,
Winslow, yes.
roll call complete.
Okay, motion passes.
Thank you. So the next item that comes up is revision of the alternative medication formulary policy. So over the years, we've had different medications that have been on shortage, and it varies from time to time and sometimes from region to region. So Dr. Winslow and his team, and I thank them for that, have put together an updated alternate medication formulary policy, which the original one was policy 1304. This new policy will allow us to continue to use alternative medications, and there is also provisions for notification to the department when these alternative medications are being implemented and when the alternative medications are being terminated from use. The actual list of medications and the alternative medications will not live in the policy as it does now. It will live in an appendix so that we don't have to change the policy when we run out of a different medication. So thanks again for putting this together. And I'll answer any questions, but this comes forwarded as a seconded motion, as a policy.
Any questions? Okay, we'll also need a roll call vote on this, please, Val.
Dr. Berkowitz,
Berkowitz, yes.
Dr. Bombard,
Bombard, yes.
Dr. Cooper,
Cooper, yes.
Dr. Cushman,
Cushman, yes.
Dr. Daly, Dr. Doynow,
Doynow, yes.
Dr. Isaacs,
Isaacs, yes.
Dr. Kugler,
Kugler, yes.
Dr. Markowitz, Dr. Marshall,
Dr. Marshall, yes.
Dr. Olson,
Olson, yes.
Dr. Walters,
Walters, yes.
and Dr. Winslow.
Winslow, yes.
All right, motion passes.
Okay, motion passes. Dr. Marshall?
Okay, thank you. There was, those are the only two action items. There was some discussion about the KIMPAC and the process, so more to come from that. It's probably the shortest medical standards committee meeting in history, so thank you for that as well. And that's my report.
Okay, thank you, Dr. Marshall. Don, from Education?
Yes, good afternoon, everybody. Don Hudson. So I'll just hit the pertinent points for the SEMAC. The Bureau is currently working through a new funding policy, which will continue to increase the funds available to our core sponsors for EMS education. So we thank them for that and continue to look towards a future of further expansions in funding. Instructor certifications for both CLI, a continuation on some discussions regarding Certified Instructor Coordinator, CIC, and then also, probably more importantly, some cross-profession from our fire service, healthcare, and education compatriots about what some sort of reciprocity process may look like is ongoing. A new co-requisite policy is forthcoming from the Bureau involving not only hazmat awareness clarification about what classes are acceptable and what are not, but also to try and roll up some of the other policies for CPR, incident command, incident management system training into one policy rather than the 2 or 3 or more that exist today. Current discussions about mentorship or field training officer programs around the regions and around the state. So if an agency or region or otherwise has a functioning field training officer program that they think other agencies could benefit from, please let us know and we'll continue to work towards that. There's been an ask of a number of different committees, but ultimately it may fall back to training and ed about looking at some sort of standards for inter-facility transport or critical care paramedic certifications. So that's one of the ongoing discussions, just for your awareness. And then most importantly, probably to this body, is the EMTCC to paramedic bridge. We have some numbers crunched from the Bureau and from Northwell from the bridge program enrollment itself. The 2 current bridge programs, Bridge 9 and 10, each have statewide about 20 people in them. And in talking to Northwell yesterday, the current bridge, number 11, which will kick off in October, has 4 applicants statewide. So I know a number of the physicians have rightfully so wanted a discussion about that, know that that discussion is ongoing, and we want you involved in that. So those charts and data is posted on Boardable for you to review so that we can make some educated decisions about sunset and timeframes moving forward. Director, Ryan mentioned a $31 increase for PSI testing. So just again to reiterate that, there is an increase, so that is effective today or as we speak. And then lastly, we do have a seconded motion that comes forth to the SEMAC for, I guess, Teresa, can you put that up? This is related to the discontinuation of the paramedic practical skills exam for paramedic originals, and it's to move in concert with the National Registry. As you know, the state of New York currently utilizes the National Registry format, more specifically the National Registry exam for paramedic originals. As they're going to sunset their exam, we should follow suit and explore what that looks like moving forward. So there are 2 letters that are put forth to the Bureau through the EDCC process for next SEMSCO meeting for actual action. I just wanted to bring it up as the committee did as a seconded motion here to keep it on the record and to continue pushing that conversation, as we believe sooner to formulate a plan is better than later. We don't want to find ourselves at midnight the night before and go, when did this happen? So the motion is motion to recommend to SEMSCO to eliminate the paramedic practical skills exam by July 2024.
Any discussion on that?
Don,
Chris,
just
go ahead.
a question. Fully support the motion to align with the National However, the CME recertification process still requires skills verifications, which are fundamentally obsolete. Should this be tied to that recertification process?
So myself and Chief Chesney and Michael Bogozzi from Education have had and will continue to discuss both paramedic refresher and CME with Mr. Myers. The committee felt that the most pressing need and the easiest lift right now is to deal with the imminent paramedic original, knowing that shortly thereafter, this group and others needs to struggle with the skills validation, exam testing that, not only affects paramedic refresher and CME, but quite honestly, why stop there? Look at everything across all levels of care would be a natural continuance of that conversation. They are tied a lot to the pending emergency education regulations, which, as Director Greenberg said, we were hoping we would be able to, codify and push forth here. Unfortunately, that didn't work out. So we're on it, just not yet.
Appreciate it.
Hi, it's Bombard. Why, I'm still unclear as to why we can't do both at once. If we're getting rid of the original, why, it's the paramedic level across the board, why are we not just taking it away? And actually, your proposal is written, the paramedic skills exam, and it's not really written explicitly that it's the original only. So why can't we just get rid of it all at the paramedic level? And we'll deal with the other levels later.
When you say both, are you referring to both original and recertification or original and CME?
Original and recertification.
So thank you for being so astute to pick that up. That was actually one of my recommendations to the committee. And as a committee, we discussed that step one is the original, step 2 and 3, probably bear a little bit more discussion and planning, simply because, as a state, not to speak for anyone else, but my own opinion and my own experience as a core sponsor has been that we have providers that are now 5 years without seeing a state written or practical skills exam, and there may be concerns about a student's level of preparedness to once again take those exams and what that might mean from a patient care perspective. So as you continue to read between the lines of what I'm saying, I think we need to have that discussion sooner than later. This is the first lift. And once the emergency regs kick in, then the Bureau and ourselves have a lot more flexibility as far as, some wordsmithing of an exam versus an evaluation or a processes or what that may look like. I agree, why not rip the Band-Aid off all at once? But I also, stand with my compatriots who then suggested, no, step 1 comes first. So I'll leave it to the committee. I mean, either one's.
I'll bring up one thing to
Okay.
think about. I wouldn't want one to delay the other. So I think, especially in timeline, and between now and July, there might be more work that can be done that could advance this at the same time. But one of the things that comes up in why PSEs on the original are disappearing is because students create a portfolio while they're going through their paramedic program. They are performing skills, they're being validated by someone, they're, with a field training officer or preceptor, whatever that term might be. And so in some cases, and the new regs or the proposed regs change it from what's called a practical skills exam to a practical skills assessment, whatever that might look like. And the tools and the system is in place today for that original paramedic student to have that paramedic skills assessment, their portfolio that they've built over the course of time. They're not necessarily in place, and even if it just means creating what that would look like for the person who's taking a refresher class, and during that refresher class, are they doing any clinical time? Are they documenting any assessment? Are they looking at any of those other things that we're using as the validation tool for the original one? And so I think that's just something that needs to be thought about. I think you can get there, but it's not as quick as here's the switch, because The question would then be, well, what is that practical skills assessment? Because for the original paramedic, it's their portfolio. For the refresher, what would it be? And we just don't know today. That doesn't mean we can get there. It's not something that's in place.
I'm just concerned because the first PSE somebody might take is the one at their refresher, is the way we're setting it up, which would be a little, I mean, it just doesn't make a lot of sense to me.
So I would give you a different timeline. Let's say the regs go through in the way that they're written. That person would be certified then for 3 to 4 years. This would go into effect in July of 2024. And if by July of 2028, we've determined that the PSE shouldn't be eliminated, then there's probably a different issue that we have to address. The others who may be affected by this would have taken a PSE prior to, because they would have taken it during their original. So I think this, it gives a pretty wide buffer span. And again, depending on the work of the committee or anything else, that could be eliminated between now and when this would go into effect. But that needs to be determined on what that assessment is, how it is, and also how it affects our programs that are doing refresher programs. We have course sponsors who may turn and say, no, leave the PSE because we don't have the bandwidth for a refresher student to do these other things or create a portfolio. There could be course sponsors who turn and say, no, we have a solution for that. Here's what it is. They just need to do it at their home agency and, perform this. And then the question also becomes, well, what about the person who's taking a refresher who doesn't practice in EMS? Or maybe doesn't even practice as a paramedic at all. They work using their skill set doing something else. How do they get assessed for this? So I think those are many of the questions that would have to be answered that I think could be, but I think the primary goal of this one is to align with National Registry for that original and to get there from that point, and then to determine how to handle the others.
Mike Daly. So, Don, you talked about ripping off the Band-Aid. Allow me to give it a slightly different rip. Why do we still have a contract with ESI for testing? Why haven't we just not moved to the registry? And do we have a timeline to just move New York State to the registry?
So no, there's not a timeline to move to the registry. There is the option, again, based on standards and regulatory changes, to have registry be an option for an exam. And then if every student chose to take that one versus something else, I think we would look at it. There's a financial cost that is significant compared to that that's administered by the state. The average cost for an exam with registry is anywhere from $100 to, I think, $170 now. The exam for New York State is $31.
But it was 28, so we are getting closer.
Yes. By like 2050, we should be caught up.
Any other questions? Okay, well, we do have a second motion on the floor here, so we need to vote on it. This will be a roll call vote as well. Well,
Okay. Dr. Berkowitz?
Great conversation. Thank you. Berkowitz, yes.
Dr. Bombard?
Yes.
Dr. Cooper?
Yes.
Dr. Cushman?
Cushman, yes.
Dr. Daly?
Daly, yes.
Dr. Doynow? Dr. Isaacs?
Isaacs, yes.
Dr. Kugler?
Yes. Kugler, yes. Sorry. I'm all choked
Dr.
up.
Markowitz? Dr. Marshall?
Dr. Marshall, yes.
Dr. Olson?
Olson, yes.
Dr. Walters?
Walters, yes.
And Dr. Winslow?
Winslow, yes.
Motion passes.
So, Mr. Chair, just in closing, a question. Does this come to the SEMSCO from SEMAC, or do I do it from Education and Training? Forgive my ignorance.
it will come from CMAC to SEMSCO, but you probably will be answering questions there, I suspect.
Ditto.
Okay. All right, moving along, Dr. Cooper, EMSC.
Thank you, Dr. Doynow. Director Greenberg, I think, touched on most of the points that I'd planned to make in the EMSC report. What I will do at this point is very briefly remind you of the key issues that he raised and give you an opportunity to ask any questions you might have about any of these issues. First, with respect to the pediatric agitation work group, that work is ongoing. We had a very fruitful meeting of the EMSC committee last week and several conference calls before that, and we are in the process of developing potential scripts for videos that may be produced as part of an educational program in pediatric de-escalation techniques, which, as you all know, really the verbal de-escalation really forms the key in the pediatric world to management of agitation, with a lesser emphasis on the medication domain. It's come to our attention, of course, that the safety work group of SEMSCO is also dealing with this issue on a broader level, including adults as well as children. And Amy Eisenhower, our outstanding EMSC coordinator, is going to get these two groups together so we can plan out a joint program that will serve the needs of everyone, adults and children, as well as folks from all parts of the state. The trauma triage education group also met. They've made a good deal of progress toward development of a guidance that will be used to assist various regions in updating providers to the new trauma triage protocols. The length-based resuscitation tape group had several meetings over the summer as well. But due to logistical concerns, these issues were not able to be brought forward at our meeting last week and will be dealt with in the very near future. The additional matter of other methods for determining drug doses in kids, such as the Hantevi method and others, have also been raised as potential alternatives to a length-based resuscitation tape. That's part of what held up the process, because these issues also need to be discussed. And we plan to have, if you will, final reports on both of these at, excuse me, at our December meeting, so that they will be ready for the next meeting of SEMAC, which I believe is in February. We continue to focus on the issue of pediatric stroke and how the management in the field will differ from that of adult stroke. There is no formal designation process at the present time for pediatric stroke centers. Pediatric strokes are few in number, and they're generally managed in pediatric ICUs, most of them sickle cell related, as I'm sure you're aware. Data is being collected to guide our thoughts on that particular area. As Ryan also mentioned, the Pediatric Emergency Care Coordinator Program is being expanded under federal mandate from the pre-hospital realm to the emergency department realm. More about that as we go forward. And of course, Amy Eisenhower continues to be deeply involved in the safe transport issues, both locally and nationally, doing a terrific job of representing New York State in that venue. And in fact, that's where she is today at the National EMSC Grantee meeting, focusing on many of these issues. I just want to highlight again, as Director Greenberg mentioned, that there's a robust pediatric program at the Vital Signs Conference this year, focusing on safe pediatric transport, de-escalation techniques for kids.
and pediatric disaster planning. Of course, I hope that all of you will be able to attend the Vital Signs Conference. I do myself plan to be there, and we're hoping that it will be the success that it has always been in the past and will continue to be in the future. So thank you for the organizers, to the organizers of that conference, and thanks to Amy for putting together everything with respect to the pediatric programs at that conference. I'll stop there, and I'd be happy to answer any questions folks may have. Thank you.
Does anybody have any questions for Dr. Cooper? Okay, Dr.
Thank you,
Cooper.
Dr. Dornow.
Thank you for the report. Moving on to old business, Dr. McAvoy.
I just want to let people know, I'll discuss this more at SEMSCO, but a motion that originated here a couple meetings ago to allow REMAX to credential providers came back to SEMSCO through DLA with some concerns. So at SEMSCO this afternoon, we'll address the concerns and form a group to resolve that issue.
Thank you, Dr. McAvoy. Any other old business anybody wants to bring up?
Excuse me, Dr. McAvoy, just because that discussion happened here at SEMAC, could you elaborate on that a little bit for us?
Let me find my note here. So essentially, what happened with Division of Legal Affairs is to tell us that the motion has no standing in statute or regulation, and the responsibility for credentialing belongs at the agency level, which our perceived solution to that is that this body and/or people from systems can create some templated credentialing requirements for agencies to use. And like anything else that we create here, regions would then have the capability of enhancing those with the approval of the SEMAC and SEMSCO. So my intent this afternoon would be to put together a working group that would consist of people from here and people from systems to start to resolve that issue. Does that answer your question?
Yeah, yes. I guess my question is, I thought that discussion originated from SEMAC, so I guess I was just curious why it's coming up at SEMSCO but not SEMAC.
The process of how motions move through the system is that it comes from here, which is a subcommittee of SEMSCO, and then SEMSCO gets told once they vote on something whether that's acceptable or not, or when it's not acceptable, we hear from DLA about it.
Any other discussion? Any other old business before we move to new business? Okay. All right, new business, just for CMAC members, if you have interest in subcommittees, please see Dr. McAvoy. We would like to get some folks involved in some of the subcommittees, if we can. We do have a presentation from Dr. Jennifer Goldman, who's a psychiatrist, on mental health issues that are now affecting EMS. And I'm not sure where she is at the moment. Over there. Hi. And I believe you have a presentation we need to put up on the screen.
Yes, hi, thanks everyone. Yes, my name is Jennifer Goldman. I'm a psychiatrist with the Office of Mental Health, and I'm here with my colleague Alexa Coppola. We really appreciate your time today and the opportunity to tell you a little bit about this new program that OMH and OASIS are working together on developing throughout New York State. I'll turn it over to Alexa to say a few words, and we'll walk you through the basics around this new program, and then talk a little bit about where we see the touch points between these new centers and EMS. Thank you.
Thank you. My name is Alexa Capola. I also am with the New York State Office of Mental Health within the Bureau of Crisis, Emergency, and Stabilization Initiatives. I do want to give a quick shout out. We also have someone else here today, Katarina Gaylord, who is our Deputy Director within our Bureau. And just a shout out, she does have some stickers for 988. This isn't about 988, but if you'd like to see them and if you would like some 988 materials, you can also use the email at the end of this slide to request those as well. If you can go to the next slide, please. And on the slide, we just have a few of our agency representatives who have also been working very diligently on the development of these centers and who have assisted in the development of this presentation. So as Jen said, the primary portions of our discussion are going to be the core components of the crisis stabilization centers and how they impact EMS providers, or how they may impact EMS providers. And I'll pass it over to Jen just to talk a little bit about how they're connected to the comprehensive crisis response system.
Thanks. Next slide. Thanks. So the development of these new centers, the crisis stabilization centers, falls within an overarching vision that OMH has been working on for New York State. OMH and OASIS together are trying to develop a statewide crisis system for behavioral health crisis, rather than kind of siloed services or programs throughout the state that come together based around 988. So you have the telephonic triage through 988. We are developing and expanding mobile crisis response throughout the state, crisis residences, CPEPs, comprehensive psychiatric emergency programs, which many of you are probably familiar with, and then a new program, crisis stabilization centers, which is what we will discuss today. Next slide. And this slide just touches on the overarching vision that OMH has for the future of behavioral health crisis system development, with the idea being someone to call. So having those 988, regional 988 crisis call centers available, someone to come, ideally that's mobile crisis teams, and then somewhere to go. So that includes crisis residences, comprehensive psychiatric emergency programs, and then the new program that we're going to discuss today, crisis stabilization centers. Next slide. And, if we build out this system in the way we're envisioning, ideally that hopefully will be less burden on ambulances, because if you look at studies, and it's probably really hard to see here the fine print, but studies have shown that approximately 80% of crisis calls end up being able to be resolved over the phone when answered with a crisis line with a trained crisis counselor. Of those that get an in-person response by a mobile crisis team, 70% of those calls are responded in the field and don't need further referral to a hospital or to a higher level of care. Of those individuals that are treated in a crisis facility, so that would be like our crisis residences or potentially these future crisis stabilization centers, approximately 65% of those individuals are discharged into the community, and 85% remain stable in the community. So our goal is really to be able to build out the full continuum of behavioral health crisis services so that EDs are no longer kind of burdened as the default provider for individuals that are experiencing behavioral health crisis. So I'll turn it over to Alexa, who will go into some greater detail about these centers.
Thank you. So as Jen noted, these are completely new programs in New York State. There are no currently licensed crisis stabilization centers. We're in the process of reviewing licenses to provide operating certificates. But it's important to note that this is a joint authorization and certification between both the Office of Mental Health and the Office of Addiction Services and Supports. This is a completely joint effort, so we do have a joint regulations, which are under Part 600, and a joint program guidance. Both of these documents encompass two types of crisis stabilization centers. centers. So there are supportive centers and there are intensive centers, and we'll talk a little bit about the differences between the two. But before we do that, I just want to talk about the similarities, that everything that they both encompass, before we talk about the separation in their services. Thank you. So it's important to note that these are completely voluntary programs. So you could access a crisis stabilization center through a walk-in, depending on the partnerships with law enforcement. Law enforcement may be able to transport somebody to these facilities. There is a requirement for these facilities to have a separate triage and entrance space for law enforcement for privacy of that individual. But it is a completely voluntary program, and the goal is to provide person-centered services with a strong emphasis on peer and recovery-oriented supports. They provide rapid intervention to individuals across the lifespan. So they are all required to serve both adolescents, families, and adults. They also serve individuals experiencing both mental health and substance use crises. So we're looking at a very overarching umbrella of services that can be provided. Essentially, what these centers look like, the intent was not for them to be emergency room programs or emergency light programs. So we're really focusing on having these spaces look safe, therapeutic, and be very welcoming. They are an outpatient service, or considered an outpatient service, so recipients can receive services for up to 23 hours and 59 minutes ideally. And they operate 24/7. And also, the biggest part of these is that we hope that they will assist with diversion from higher levels of care, as Jen noted. In many communities, an emergency department is the only 24-hour crisis option for individuals, and in many cases, individuals who are seeking services may not meet the requirements for an inpatient stay. So this is an option for those individuals in their communities. We're going to skip over this slide, but it will be available. It'll be available on the website. So we'll talk about the primary differences between the supportive and intensive services. So on the left-hand side, you'll see all of the services that every crisis stabilization center, supportive and intensive, must provide. So this is from triage, screening, and assessment, all the way to discharge and aftercare planning. This is also inclusive of a follow-up component in order to connect individuals and make sure there's a direct connection with their wraparound services. And everything on the right-hand side, these services are what intensive crisis stabilization centers will specifically provide. So really the only differences between supportive and intensive is obviously community planning based on the provider needs and the area needs. If the provider is looking to open a supportive or intensive based on the crises that they're experiencing in their communities, but also what partnerships are available. So an intensive center will offer these additional subset of acute services. So that spans from psychiatric diagnostic evaluation and planning all the way to mild to moderate detox services, as well as medication management. And it's important to note here that the supportive crisis stabilization centers, while they're not offering those specific services on site, they are required to have partnerships and linkages to those services or providers who offer those services within the community. So if somebody presents and it's assessed that they will need one of these services, that there's a direct, immediate connection to those services. Do you want to add anything to this?
The only thing that I'll add is just that we see this as a really important piece of the puzzle that does not currently exist, which is that an individual that is looking to seek treatment at whatever intensity of a crisis can walk in the door of one of these centers and get help. They don't have to wait until business hours. They don't have to walk into an ED if all they need is to be able to be connected to resources in the community. If they need more urgent help, where they need medication started right away, especially if they're experiencing withdrawal from substance use, the goal is these centers will be able to start 24/7, initiate buprenorphine, be able to address mild to moderate withdrawal symptoms. They will be resourced in such a way, there'll be a nurse on site 24/7. The intensive programs have prescribers available 24/7. so that, this is openly accessible to individuals at the time that they need it.
Thank you. So I'll touch upon the importance of the peer services here, and I won't go through the next slide, we'll probably skip over, but you'll have it for accessible to you. This is really important to the vision and philosophy of these programs, essentially really to differentiate them as well from emergency room programs is the focus on peer support and utilizing individuals with lived experience to not only provide direct services in these centers, but to build out the programs themselves. So we've been having these conversations ongoingly with providers on the importance of peer specialists and looking at our peer network across the state. But ultimately, peers have this shared lived experience with individuals and families across the lifespan who are experiencing both mental health and substance use crises in their various disciplines. And we really do think that they're the leading experts on the resilience and recovery-oriented support services. So like I've said, part of this philosophy is building in individuals with lived experience throughout the program model to ensure that the vision and philosophy of these hold true. Thank you. And another important component that I touched upon is that all crisis stabilization centers will provide services to individuals across the lifespan. So there is an expectation for there to be staff available with expertise in training and child and adolescent development, and we are expecting these staff to be available 24/7. We've also been talking with providers about how to build out the space. There will not be commingling of adults and children, but how do you create a space like this without separating into two separate spaces? So we've been talking about this, but ultimately utilizing different methods within the premises to limit commingling as much as possible, and that's what we've been talking about. So there's also an expectation to collaborate with providers in the community who provide services to adolescents, including younger adults. So this includes schools, pediatrician offices, and whatever's available in the community in order to make those direct linkages to care. As we all know, there is a shortage of services for children, so that'll be important. Thank you. Okay, if you can go to the next slide. So I'll just quickly touch upon the staffing requirements, and I think Jen touched upon this a little bit. But for an intensive crisis stabilization center, there will be oversight of a medical director, as well as 24 access to a prescriber. For all crisis stabilization centers, they are required to have a program director, as well as at least one psychiatrist, or a psychiatric nurse practitioner, as well as a CASAC and a certified peer specialist. And these individuals are required to be on site or have the ability to come on site as needed. And as well, they must have a registered nurse available 24/7. So these are the minimal requirements, and we continue to talk about the build out of the multidisciplinary team within these settings, really looking at what the community needs in order to make these projections for how many staff will be needed in their various disciplines. So looking at the populations that these centers are planning to serve, and so on. And a very large component of a crisis stabilization center, in order for it to be successful, is very strong community partnerships and collaboration, which is why we're very thankful that you're having us here today, because part of the requirements of the crisis stabilization centers are not only to have partnerships with the local government units, but to reach out to all providers within their crisis response continuum and to establish partnerships with law enforcement as well as emergency medical services in order to discuss how transportation may happen, how drop-off may happen, but also to understand where this service fits into the larger community system. Thank you. So just so that we can talk more about the larger impacts this will have on EMS providers, I will just note a little bit about the development across New York State. We have provided funding for the development of supportive and crisis stabilization centers across New York State. Specifically at this time, 22 crisis stabilization centers are in the full swing of development. And at your leisure, in your time, we do have the specific providers included on these slides and the counties that they plan to operate in. Thank you. I'll pass it over to Jen.
Thank you. So we just want to take a few minutes to discuss a little bit more about where this fits into sort of the crisis system, emergency medical services, which we recognize will vary regionally throughout the state. But generally speaking, there'll be a potential variety of touch points, one of which is ideally if we are messaging this out to the community, though it will be, ideally clear to individuals and to providers and to agencies that, when someone should be going to an emergency, department versus when someone might seek treatment at a crisis stabilization center. One major differentiating factor is, as Alexa had mentioned, these are voluntary settings. So individuals that are voluntarily seeking help for a condition, and are not at an imminent risk to hurt themselves or others, would very well be served in a crisis stabilization center. There are going to be times likely where someone may present to a crisis stabilization center and start in that condition, and then something may change. Maybe they end up getting, experiencing complicated withdrawal, or maybe there's an unrealized medical condition. So where there may be touch points between EMS and these centers is a medical emergency or issue arises at one of the centers, and it turns out the center realizes this person needs to be referred to a hospital for a higher level of care, in which case they would be calling 911 and they would be activating that response. We think it'll be great, though, for EMS to be familiar with these centers, to know what they're responding to, what staff is on board, and ideally, as Alexa had mentioned, the providers of these services are going to be expected to be reaching out to their local emergency medical service providers to be able to build those relationships prior to even opening. We hope that in the years ahead, we can partner with all of you here to discuss other ways that there might be connections potentially to help foster this goal of really diverting individuals away from that default kind of calling 911, going to the ED to receive support for a behavioral health crisis. The potential for there to be EMS transportation to a crisis stabilization center when appropriate, we think would be a great option. It might be the case that these centers are closer than neighboring hospitals. It may be the case that it can offset some of the burden for those EDs. So that's we just wanted to have this introductory discussion to open the door. We look forward to collaborating with you in the future and getting feedback about how you see this potentially developing, how this can be most helpful to all of you, and potential future directions from there. Thank you.
Well, thank you for a very interesting presentation. Does anybody have any questions?
Thank you very much. Hi, my name is Louis Marshall. So this is a voluntary program, so a person would voluntarily say, I'm in crisis and I need to go there, right? As opposed to, calling 911 and being picked up, and then 911 services having to decide where they should go, correct? Is that?
Thank you. That's exactly right. So an individual that would not be appropriate for this setting would be, for example, someone maybe that's agitated in the community, and a passerby is saying this person needs help, and the person is not interested in, receiving help, and there's concerns for things escalating or violence, or an acute medical condition or intoxication where they think, the person needs a full medical evaluation before determining the etiology of what this crisis is, that would be someone that would continue to go to the traditional sort of process.
Okay. Yeah, I think one of my concerns is that because of the overlap of symptoms caused by medical conditions and those caused by behavioral health commissions, that patients may wind up in the wrong place. But, yeah, so.
Yeah, I think that's where we really want to proceed slowly before we consider, for example, having ambulance drop-off to these centers. I think that to start, this would mostly be voluntarily people walking in of their own volition and seeking care, potentially police drop-off if there's a police touch point and police, as a diversionary option, ideally to move away from arrest or other things to be able to drop them off to the crisis stabilization center. I think we feel when it comes to the decision of potentially, EMS or ambulance involvement, I think that would have to be a very thoughtful discussion because it's a very, there's a snippet of what you're seeing in the field to then determine whether someone does need that full hospital evaluation versus a community-based voluntary program. So I think that would be a great future direction, but I think to start, we see this more as individuals walking in, being dropped off by loved ones. There still likely could be situations where, as the CSC team is assessing and triaging an individual, the vital signs are concerning or, someone gets agitated. And that's why we really want them to have strong relationships with neighboring hospitals in the event that there has to be an escalation and a referral to higher level of care.
But I think that we would all appreciate anything you can do to help reduce the burden of behavioral health in our emergency department. So thank you for that.
Could I ask a few questions? So this seems like a really good referral source where there's many times when we refer people rather than transporting them. So this seems like a really good program. Do you have an anticipation of making more than 22 of them?
At this time, the funding that was available was for the development of 24. At this time, 22 providers had interest in opening them and were awarded some competitive funding for it. But the certification process is open to any provider who would like to operate a crisis stabilization center. The 22 who are developing just happen to be providers who were provided some state aid to open these.
Is there a place to get a list of where they actually are?
I did include them in the slides, so the slides will be available, but they're not publicly available anywhere else. So if you have access to these slides, which I know will be public-facing, that has the list of providers and counties they plan to operate in.
Okay, it looked just like there was a listing of counties, not really locations specifically.
As they get closer to opening, I think we're going to be trying to do a lot of outreach to the communities and providers to make sure that everyone is aware. The other thing is that these services are billable, are Medicaid billable services. So the hope is that they've been designed in a way that can be self-sustaining so that even providers that may not have been awarded the startup funding, if they decide they want to pursue this, that there's the opportunity for additional centers to develop over time.
Okay, and then I guess down the road, important to us are any or all of these Article 28 facilities?
You may want to explain that to them, there, Mike.
Licensed under Article 28 of Public Health Law.
They're licensed under Article 36.
What's the capacity of these centers? Are we talking they'd see 10 patients a day, or are we talking they'd see 100 patients a day?
It's going to depend on the region and the other, I think, available services. As part of the RFP, the providers were asked to include a projection of what they anticipated they would have, the number of individuals they would anticipate to serve. But this will be a learning process. I mean, this is the first time that this service has been developed, and so I think we want them to be developed in a way that can grow, depending on the need. I think it'll also depend on how well we do with messaging to communities that they exist and to providers to make sure that they're actually being utilized to the maximum that they could be.
Do you have a timeline as to when you're going to be up and running? And
Based on the provider and where they are in the process, it's at various stages. We do expect a number of them to be fully operational by Q3 of 2024.
Anybody have any other questions? Go ahead, guys. Dr. Cushman?
Jeremy, sorry, Brian. Okay, sorry, dude. Jeremy Cushman, we just met. A couple of things, just having been a part of an OMH pilot that will soon become a crisis stabilization center, and frankly, that's going to disappoint me because right now they are receiving 941s, which is incredibly important for our community, given that status. With all of that being said, I fully agree with Dr. Marshall. Anything that we can do to identify more patient-centered sources of care for those with mental health, substance use, or other crises is really imperative. But at least based on my experience and of a good friend down the table here of navigating this process for the last 4 or 5 years, I am really happy that you're here. I do think, however, that whatever OMH can do to, frankly, force these CSCs to engage and at least notify the program agencies within the communities that they operate and the EMS agencies within which they operate so that we actually know that they even exist. Because it's frankly a little concerning that if they need to go to the hospital, they're going to call 911. That's not good continuity of care. Many of these patients don't need an ambulance at all, particularly if they're voluntary going in for an inpatient admission. And that is not a problem unique to CSCs. It is a problem everywhere. But the vast majority of these individuals should not be in the back of an ambulance for a lot of different reasons. Medical needs notwithstanding, I think there are some opportunities there. I personally look forward to working with you and hope that we can bring things back here to identify what are clinical standards that are reasonable and appropriate for individuals going to this, if you will, class of facility, just as this body makes those decisions for strokes, STEMIs, and any other clinical indication, understanding that there is a tremendous heterogeneous and difficult to diagnose population within there. You also mentioned the ability of law enforcement to potentially bring these, again, as the system's EMS medical director, that falls to me too. And they're going to be looking for guidance. So the more consistency in the guidance that we can provide statewide, understanding that there may be some regional variations is going to be absolutely critical. Because the other thing that can very well happen is that the cop calls EMS to get an eval for medical clearance before they take them to the crisis center, which frankly may be completely appropriate, but I don't think we have much guidance across most of our systems as to how to do that, and that gets into a resource allocation issue that none of us have the resources to be able to do to begin with. So, kind of with all that being said, alternative destination is also huge. EMS gets a lot of voluntaries. They're not all 941s and 945s that are getting transported by an ambulance or 950, whatever it happens to be. We get a lot of voluntaries. So again, the sooner we can look, and maybe it's at a community level decision based upon the capacity of that facility, because frankly, I don't want to lose the ability to have, it's not huge numbers, but have small numbers of our patients that are either voluntary or actually under 941 going to our future CSC. Sorry, it was more of statements, but just like, we got to work together on this one because it's
Very, very helpful statements. You might have noticed all of us jotting things down as you were saying them, but I think you bring up very good points, and also, important lessons learned from the work that you've done, with the center that you're working with. I think that, as you described, we really are looking to make some statewide standards, guidance around who would be the appropriate, what type of case or what type of individual would be most appropriate for this setting, those that would not, and really try to distill it down in a way that, knowing in an emergency response setting, you're not going to go through 20 different questions to try to streamline. You're really trying to, distill it down, ensure that the person gets to the safest, most appropriate, receiving center as quickly as possible. I think you bring up a good point also about the regional variability, and I think that's where we do see a lot of this work, hopefully over the course of the year, is then thinking about what is potentially currently working in one region. Our goal is not to undo systems or processes that are working. It would only be to augment or to add to. So I think that while there might be some standards that we have put forth already about, the types of individuals that these centers are receiving, if there's a system that is working, I think that OMH and OASIS will be very open to thinking creatively around how to, support that system to continue to work.
And I just want to note and bring back Jen's comments about this being a learning experience for providers who are opening them as well. So, and I want to second your last comment, that there will be, if there is something that is happening and it's working well, that providers are very open to looking at it as well. We have started a monthly learning collaborative with these providers who are in development, and we're still talking about the early phases of what do they want to see come to these discussions in order to have these conversations. So this is a great point, and they're also looking for what's working well across the state to have ideas. So at this point, having them all in a space to be able to collaborate is good, and I think being able to incorporate various EMS providers and law enforcement officers who are doing some of this work currently to come in and have these open discussions is what it sounds like the providers are looking for and what we're definitely hoping to facilitate.
Dr. Walters?
Just real quick, I was going to say many of the same things that Dr. Cushman had mentioned, so I appreciate that. Thank you. But I guess I would just come back to the point of a lot of people, no matter how you roll this out and how much education you do, a lot of these patients or their families at the time of crisis will still access healthcare through the 911 system, right? Because it's familiar and it's what they know. And whether that patient then encounters law enforcement or EMS, I guess you're talking about having law enforcement potentially drop them off to these CSCs, but not EMS. And I understand the slow rollout and wanting to try to put systems in place before you kind of start accepting all these ambulances. But I guess from a medical director perspective, I'm not sure a lot of times if it matters whether it's law enforcement or EMS that first encounters that patient and or transports that patient, because they've accessed the system the same way. And I don't know if differentiating and parsing those out clinically makes a lot of sense from the types of people that we see in the community. I do agree patient selection becomes hugely important to make sure we're getting the right patient to the right resource, because some of them will need more inpatient, longer stay psychiatric hospitals, right, as opposed to a CSC. But I guess those are just things that I would consider looking at a little more closely or implementing in short order, because I think that would directly impact and offload both EMS and the overcrowding we see in the emergency departments.
Thank you. And I mean, I think that the development of this program is in parallel with some of the other work that OMH is doing and nationally around the development and expansion of 988 as an alternative call center. I think, ideally, over time, the needle moves and people are calling 911 less for behavioral health crisis and calling 988 more, especially as we can build out that mobile crisis response. So there is an alternative sort of response entity that will go assess the scene and then potentially bring the individual to a crisis stabilization center if that's appropriate. I think that what you described is absolutely correct. When you think about someone calling 911, it may be police responding or police plus EMS. Then it's sort of no different if they're then going on to the center. I think where, at least locally in New York City, where we've seen some of the police drop off has been more about touch points in the community where there may be, it's not through a 911 activated response. It's more of police is engaged with an individual They feel it's possible that there's a mental health component to this. They don't want to necessarily pursue the criminal justice route, but they also don't want this person staying in the community without having some sort of an evaluation. So I think that's more of where we see the police drop-off piece. But for a 911 call with a response, I think you're exactly right. Like whether that ends up physically being the police or EMS, it's still that same question that there was a crisis that raised to the threshold of 911 being called and wanting to really do your due diligence before you're not taking the person to the hospital. So yeah, I think that's a very good point. And as I said, I think, there's work being done for, between 911 and 988 as well to be thinking about how to potentially appropriately and safely divert some of those calls that are coming into 911 over to 988 at the start, so that, because at this time in most locations, someone calls 911 and you've got just a few options. You have police response, you've got a police and EMS response. So I think that if you can divert from the top over, then you have more ability to then utilize those other options without it always having to, fall on EMS to be bringing someone to a hospital.
So, I'm sorry, go ahead.
Any other questions?
I just wanted to add on to that,
And
if I can. Okay, thank you. There have been ongoing conversations as well with the 911 Coordinators Association for about 2 years, just trying to understand the nuances of what it is for them to receive behavioral health calls into 911 and how that can coordinate with the 988 system. And we have some contact centers who have started pilots, if you will, with their 911 locations where they're co-located. And so that there are some protocols that have been developed for these certain centers to do some triaging of calls from 911 to 988 and then 988 to 911 based on what they have seen for their volumes and presentation of callers. So as we continue to assess this as part of the developing comprehensive crisis response system, this is all information that will be shared for the other components as well.
Dr. Winslow?
Yeah, I just want to say thank you for your presentation. In Suffolk County, we've had one of these since 2019, and they filter out hundreds of calls that otherwise would end up in the 911 system. But the way we separate it is between 911 and 311. So if 311 is called for someone who has an issue of depression, mental disorder, substance abuse, they're directed, if they may, self-direct to this facility. It works quite well. Also schools, because a lot of these are adolescent and young adults, so school and colleges also have programs where they can refer to this program, and it's been very successful.
Go ahead.
Yeah, Mr. Chair, Jonathan Washko. So thank you guys for this work. This is awesome. It's great to see the state catching up. Many of the issues were being discussed here. These programs exist in many other states already. Ambulances are taking patients to these types of facilities in other parts of the country. I don't think we need to reinvent the wheel. I would ask, as you guys are building these facilities out, that you consider the intake process and the logistics associated with an ambulance coming to a facility to drop a patient off like that, and how your whatever the requirements are for your facility. One of the things we noted in ET3, in our participation of that and looking at alternative destinations, those are some important things, to consider, as well as the ability to communicate with the EMS system if they're dropping patients off, things like that. Like I said, I think, in Innovations and Research Committee, we made a motion that hopefully will be coming to this body today about building a framework for alternative destinations, because ultimately we need something. This would be, I would think, a subset of that. Whether it's taking patients to an urgent care or taking patients to a crisis facility like this, is clearly going to be part of, I think, future for EMS, as well as the movement of 911 calls over to the 988 centers and vice versa. I mean, it's all good stuff. I think we should be ahead of this, or working in parallel. And like I said, I would ask this body to consider putting, either a tag together or a special group to be able to start working on what does that protocol look like from an operations perspective, from a clinical perspective, some guidance maybe for the regions. Because ultimately, I think we would want to have a standardized approach to this versus, variability all over the place. So, thank you.
Dr. Cooper, then Don Hudson.
Thank you, Dr. Dono, and thank you for the presentation. I have the honor of chairing the Emergency Medical Services for Children Advisory Committee to the State Department of Health. I know you did mention that you're incorporating planning for pediatric patients in these in your process. I think first that, as has been suggested, patients who are significantly agitated are going to constitute, a large percentage of the patients that EMS will be called to see. And of course, as I'm sure you're aware as a psychiatrist, that the issues are a little different for the kids than they are for the adults. Not entirely different, but different enough. But given that we are embarked on a major project to develop both adult and pediatric de-escalation, not protocols exactly, but guidances in terms and education as to how to deal with agitated adults and children. I wondered if, in addition to speaking here, we could invite you to come to the December Emergency Medical Services for Children Advisory Committee meeting and lay out your plans. I think you may get some good feedback from some of the pediatric critical care and emergency medicine physicians who serve on that committee, and I think that may help all of us, come to a place where we can ensure that kids are faring well within the system, particularly with respect to the individuals staffing those centers that may not be as familiar with pediatric issues as they may or may not be familiar with adult issues. Thank you.
Don Hudson.
Yeah, 2 minutes, I promise. So just to put some color to this from the EMS coordinator or the program agency perspective, as Dr. Cushman mentioned, so literally 2 weeks ago in the office, the phone rings, I answer it, and the first thing they say is, "Hi, how wide of the doorway can your ambulance stretcher get through?" And, obviously, "Hi, who's this? What are you asking for?" And it turns out it was Central Nassau Guidance, who just got a ton of money through a grant that they're renovating one of their facilities for this. And in doing so, they want to make sure that for future, years down the road, reception of ambulances, that their facility is commensurate with our logistical needs. So thank you for coming here. Thank you for putting us together in the infancy of this. And those questions are going on. I just want to make sure we get the right people together to continue building out this thing for the benefit of everyone. So thanks.
Any other comments? Well, thank you very much for your presentation. Oh,
No,
Dr. Daly.
I was going to say thank you. My follow-up was to Don, just to say how exciting that was to have someone reaching out, asking about ambulance stretcher dimensions, because municipal building code still does not require ambulances to fit in stretchers for multi-story buildings. That would be nice.
As well as elevators.
Just to plant the seed, so they literally, on a hunch, did a Google search to try and find that out, and then, as EMS coordinator, they came across my phone number. So now's a nice time. If somebody hasn't reached out to you, and then there's a place on your list, or in your county that is being built out, maybe an introductory, "Hi, who are you? This is who we are." It's time.
I got to take this moment to also ask, how'd they figure out that you were the EMS coordinator, or even to look for an EMS coordinator position?
The same way I never heard of the 911 Call Center Association or anything. I mean, just by sheer happenstance. Literally a Google search. So, people are at least mindful that EMS exists and we have a stake in this game, which I don't know was ever really happened before. So
I guess I'm just excited that they figured out what an EMS coordinator was, and is there more things that we can do to kind of promote that, so when people have questions or trying to make that link, they know a person to go to in each county?
they were even more excited when I just sent them the product specifications from the stretcher manufacturer. They're like, "Oh, we'll show this to our contractor, thanks."
Okay, thank you. Appreciate the presentation. Before we move on, any other new business anybody wants to bring up? Go for it, Mike.
Mr. Chair, just two things. One, the funding policy and the new pilot program policy are up. They're on the Bureau website for anybody who would like to, as well as also I'll put the plug back out there for anybody who wants to do a survey. It's on the EMS forms page. And the EMS advisory related to equipment selection that has to be approved by the medical director of the agency is also up. That is under on the Bureau of EMS page, under protocols and advisories, under SEMAC advisories, it is 23A, and it is that protocol or that advisory as well.
Thank you, Ryan. Dr. Daly?
So there's a paper recently written that I wanted to bring the attention of this body, less because of our role in advising the commissioner about EMS and more about our role in advising the commissioner on emergency departments. But it was a paper written by Jeff Kampta et al. And the folks in Rochester, including our own Dr. Cushman and Dr. Dorsett, who have been extremely valuable, obviously, as we've discussed. And this paper actually was really interesting because what they focused on was information transfer between ambulance crews and the physicians and providers caring for patients in emergency departments. The title, Improving Emergency Medicine Clinician Awareness of Pre-Hospital Administered Medications. And what they did is they looked to see how many people that received dexamethasone pre-hospitally received additional dexamethasone in the hospital. And they found out that about 35% of people received the same medication again without any clinical indication for a second dose. So they went through a series of PDSA cycles, exactly the way you're supposed to do, a really good quality initiative, and tried a couple of different solutions to try to improve the process of information transfer so that the ordering clinicians wouldn't reorder a medication the patient had already received. And after two very well-structured PDSA cycles that they describe very nicely in here, they still had 30 to 35% of the patients getting dexamethasone again. And the problem is something that I think that we have the potential to start considering solutions to. We are moving towards electronic health records. We are moving towards actually rather robust electronic health records. But we're doing that in a silo. In some cases, it's agencies' silos, when ambulance agencies decide they will just randomly have their own medical record. In some, it's just a silo within EMS itself. We have our image trend bridge that ultimately brings these siloed records together, but those siloed records don't ultimately become discrete information at the hospital end. In many cases, they still remain flat PDF files somewhere hidden within a record system. One of the things that we're doing locally right now is building out Epic across one of our health systems. That health system is looking to integrate EMS data as real data, as opposed to flat files. That gives us the opportunity then for those medication administrations to be actionable information in the hospital. So that while I understand that with an Epic build you have the potential for lots of little pop-ups all over the place, this would give you the opportunity to get a pop-up when you order dexamethasone for someone who already received it from EMS. I bring this up as new business just because I think we can do things better. Dr. Goldman and her team came here to give us new ideas about how to handle crisis, which is fantastic, and some of the things that are being done there. This is something where our hospital systems are implementing new electronic health records. They are very frequently choosing to save money in that implementation by not integrating EMS records as discrete data, but as flat files. And we can, as a body, recommend ultimately to the commissioner that we encourage our hospital systems as they look to improving their delivery of care through electronic health records, that they make sure that EMS data system or EMS data is included within the patient's record. Because at the end of the day, it's not the hospital's record, it's not the EMS agency's record, it's the patient's record, so we can care for the patient as optimally as possible. So I bring that here just for us to start thinking about, to see how we could impact that within our mandate to advise the commissioner on emergency department integration for EMS, and just to keep it out there as an idea we'll consider.
Just a quick question on that one. I honestly don't know the answer. When information goes through a RIO, does it come to the hospital as flat or does it come as dynamic?
So one of the problems with the regional health information organizations is that that is information that you actually have to go and seek. It's not information that automatically integrates. As long as you have to pull things rather than it being pushed to you, it is less actionable at the time of care, unless you did make a volitional decision to go and seek that out.
But if you go and seek that out, does it come across as flat or does it come across as dynamic?
It can come across both ways depending on the information itself. Usually, it's a flat file.
Usually it's a flat file, okay. I was trying to figure out if maybe some of the work for what you're referring to has been done and we can look at it from that point of view.
Actually, most of the work has been done already. Other Epic builds in other parts of the country already have these integrations done. Image Trend, ESO, and EMS charts, for 3 examples I know of, all have robust systems that can actually bring discrete data across into hospitals themselves rather than just flat files. It's a question more of how the hospitals are recording this information, how they are choosing, more accurately, how they are choosing to consume that data. And the easiest way to do it is as a flat file, because it's just like any other fax. But the more we can get that information to be actionable, real data that can fit into the hospital systems, the better off we'll be.
What do you think your recommendation or component would be for that? I'm not saying to make it, automatically, how do we get from here to the finish line, but what do you think that first step in discussion or things that, from others around the table have done in order to help facilitate that or push that?
I think the first step is what Maya and her team and Jeremy's team out in Rochester did, which is study the problem and see that we really do have a problem and what that potentially could mean. I think the next step after that is for some of the EMS leaders at this table, and particularly the emergency medicine leaders from their hospitals, take this back home, look at how their systems are using this, and then for us to come back together, usually at the break between meetings, and talk about how this ultimately can impact us. This may have to be something that the Public Health Planning Council deals with more than we do, but we actually have a mandate to work on emergency departments. And it may be something that needs to fall to the STAC and to the Cardiac Advisory Committee for STEMI and stroke and all the other places this information becomes extremely valuable in the hospitals themselves. But I think we just have to start thinking about it and talking about it.
I'd be happy to have a first conversation either in between meetings or schedule a meeting in between actual meeting dates to see what we can do to kind of push that forward. I think it's an important one. I think it's something that, reality is it won't happen overnight, but if we don't start the conversation at some point, it's not moving the process forward either. I would also say that, we strive just to get the flat file over, let alone a dynamic file, and that's challenging in itself in each region. And then like the 17 EPCR vendors that we have in New York State today, hospitals have a similar issue of, what electronic health record are they using? Granted, 50% being on Epic, but so I think there's some dynamics, but no, I think it's a great thing, and I think we should move forward on that.
Dr. Cooper?
Thank you, Dr. Doynow. I think Dr. Daly, in citing Dr. Cushman's work, has really touched upon an issue that I think has, concerned all of us for many, many years, which is, the the weakness of the interface between EMS and emergency departments, across the board. We all know that there is provision in regulation that emergency departments are required to have interface with EMS on a regular basis. There's also a provision in Article 30 that gives the SEMAC a role in helping to develop appropriateness review standards for emergency departments. One of which could be focused on the issue of the interface between pre-hospital and in-hospital emergency care. There was a work group that met briefly maybe 15 years ago now when Mr. Ronsky was the director that began to think about these issues. Dr. Marshall may remember that work group. I think he was part of it. It might even have been before Dr. Doino's time. I don't know. But it is an issue that has never been really addressed as well as it could be. And I certainly do think that the better integration between pre-hospital and in-hospital care is an important facet of both the original and the follow-up EMS agenda for the future at a national level. And I think it's something that it really behooves us to try to, focus on in some way in the future. I think that focusing explicitly on the interface, I think, is between the two phases of care is a really good way to start, and would urge that the Bureau consider pulling together a work group to start thinking about these issues. Thank you.
Thank you, Dr. Cooper.
So I would, John Washington again, there is a project going on downstate in New York City where the hospitals are working together with HealthX and SANCIO or Health EMS in order to try to bring XML level data, not just CCD or flat file data, into the actual EMR systems. We're going through an Epic build. We'll be doing the same thing as Dr. Daly mentioned, trying to bring EMS data in. These exchanges already exist. Ultimately, like you said, oftentimes it's a budgetary issue on the hospital side, and I think that the technology is there and it's easy to get done. The hard part is finding the dollars to do it. We already have a standard. It's NEMSIS, right? So it's easy for us to get, I think, our data to other places. Other places like even while HL7 and some of them was it FIRE, I think are the other languages on the hospital side. I've seen that it's a lot more challenging to get hospital data out in a discrete and structured way than it is. EMS, I think we've done actually a really good job, and we're actually kind of ahead of the power curve when it comes to our ability to move data and have it in a structured way, and it's one language across all EMS entities. So I think we're well on our way, and but it will require some funding as well.
Any other discussion? Dr. Daly, thank you. Would you be willing to form a work group maybe with Dr. Cushman in New York City and come back to the committee maybe in December? And at that point have a motion that we can send up to the commissioner? It's certainly an excellent idea, and it certainly can be built in. I'm a long-term user of Epic. All the pop-ups that come up. So this would be a great pop-up to have, to know that the medication be given if you're trying to order it, and it's already been given. Okay. Any other questions at all before we move on? Any other new business? Okay. Our next meeting is December 6th. Just one thing I do want to mention to the physicians who have attended today, thank you for coming. We do have an attendance issue. Please remember that we all wanted 4 meetings a year, and also that we try to help everyone out by moving the physician meetings to 1 day rather than 2 days. Please come. I mean, we need 13 people for a quorum. We had that today. There are only really a couple of physicians who do not show up on a routine basis. I will reach out to them. But we do publish the dates for the meetings now a year in advance. We really need you to come. Missing a meeting can potentially give us a problem with having a quorum, which is a problem. So please come to the meetings. All right, on that note, I will adjourn the meeting. Oh, Dr. Kruger.
I would like I'd like to make a motion to adjourn, please.
Thank you. Can we second? Anybody second? All right, anybody against? Great.
I'm against.
Meeting is adjourned.
I pledge allegiance So yesterday, Tuesday, 22 years ago, was September 11th. Committee meetings, the first of which was Med Standards, didn't start until 10. So at 8:46 in the morning when the attacks on America began, most of us were at breakfast with colleagues. And I'd like to just take a moment to reflect on the thousands of lives lost that day at the World Trade Center, on the Sacred Field in Pennsylvania, at the Pentagon, and the thousands of lives lost to World Trade Center illnesses since then. Thank you. Could we call the roll?
Allison Burke. Stephen Katie.
Stephen Katie, present.
Scott Clark.
Present.
Dr. Krupe. Okay. Mark Devers. Don Duval. Michelle Fornes.
Mickey Fornes here.
Carl Gandolfo.
Carl Gandolfo, present.
Gregory Gill.
Gregory Gill here.
Jason Haig.
Jason Haig here.
Teresa Hamilton.
Teresa Hamilton, present.
Don Hudson.
Don Hudson, present.
Dr. Isaacs.
Isaacs, present.
Al Kim.
Al Kim, present.
Stephen Kroll. Steve Kroll. Andrew Knoll.
Here.
Jared Cutzen.
Here.
Al Lewis.
Present.
William Masterton.
Here.
Mike McAvoy.
McAvoy here.
Beth McGowan.
Present.
Mark Philippi.
Philippi, present.
Marianne Portoro. Dr. Raybridge.
Raybridge, present.
Dr. Redlener.
Redlener, present.
David Simmons.
Simmons, present.
Carla Simpson.
Carla Simpson, present.
Christopher Smith.
Christopher Smith, present.
Chad Smith.
Chad Smith, present.
And David Violante.
David Violante, present.
We have quorum.
We have a quorum, thank you. First item of business would be to take a motion to accept the minutes of May 10th, 2023, our last meeting.
I'd like to make that motion. Elizabeth McGowan.
Do we have a second?
Teresa Hamilton, a second.
Any discussion, corrections?
Steve Katie, I was not at the meeting. However, I did notice when I reviewed them, it lists the chair on the very first page is Mark Philippi. And it also, my name was misspelled in the attendance when it was taken.
I'd like to amend my amendment to accept the minutes as corrected. And I will second that.
Any other corrections or additions?
Mr. Chairman, on one of the pages, it mentions the Royal EMS Task Force. I believe that should be rural, RU, rather than ROY.
So we'll change the Royal EMS Task Force to rural.
I do feel that the rural task force is quite royal, though. I just want everyone to know that.
Any others? So all in favor of approving the minutes with those corrections, signify by saying aye. Any opposed, same sign. Any abstentions? Carries.
Next item of business is correspondence, and I have no correspondence that was addressed to SEMSCO or to myself as chair. Next item after that is the chairman's report. I want to talk briefly about the bylaws tag. As you know, the summer was very, very busy with committee work. I think I got invites to about 47 committee meetings over the summertime. So I put off the bylaws tag work until between now and December, so we should have a report for you by December on some changes to bylaws. The second thing I wanted to talk about is boardable training, and I had suggested that we do some boardable training for SEMAC and SEMSCO. There are some changes coming to boardable to make things a little bit easier to find. But also we need to do some work internally to be more consistent in how we post things on Boardable. So between now and December, we will come up with some processes that sort of standardize that for everyone. And then in December, we can do some brief Boardable training by Chief Weidman on how to use Boardable. So that's my intent at this point. And those are the only things that I have in the chairman's report at present. First, Vice Chair.
Thank you, Mr. Chairman. Jason Haig, first Vice Chair. I think we need to have a roll call before we proceed any further for attendance, do we? We did do that. Never mind. I'm sorry. I was too busy writing my notes over here. No report for the first Vice Chair. That's why we need lunch before these meetings.
You may be transferred to the Royal Committee. Second Vice Chair.
Good afternoon. So a number of things to talk about here. First thing is that working with Terry Hamilton at the suggestion, we came up with a one-sheet piece of paper that shows all of the committees of the SEMSCO and their mission and vision. It is all printed up. It's on a table over here by the doors going out. As we've said, if anybody is interested and wants to get on any of the committees, please do so. If you want to see what they all do, that document is over there and will be available on Boardable as well. And so that's item number one. Item number two is that I just want to give a quick update on the iGel program. It seemed to be a place to fit it in. And that is that it's ongoing. It's going pretty well. There are a lot of issues in terms of data and getting data out. What the Hudson Valley region has done has started reaching out to all of the folks that are using the iGel program and going over pros and cons, what's good, what's bad, what's happening, do they like it, is it working, how many uses they have, and getting those documents to the Hudson Valley region. Right now, we're seeing on average 3 times as many uses as data we're getting. QA is still ongoing at the agencies. We'll provide a better report on actual uses and some analysis at the next meeting. But all the agencies say it's going really well, and it is very useful, and it's super helpful. So that is the iGel component of this. The last thing I have is that it's that time of year for nominations. And so I am going to open up nominations for the chairperson. Excuse me, sorry. Yes, for the chairperson's position, for the first vice chair position, and the second vice chair position. We'll open those nominations at this meeting. We will close them at the next one. I will take nominations from the floor up through when we close the nominations at the next meeting in December. Also, I'm looking for anybody who's interested in serving on the nominations committee as we move through this process. So I'm opening them up for those positions, and the first thing I would like to do is to nominate Mike McAvoy for chairperson for next year. Okay.
Do you need seconds for these nominations?
I don't think we need seconds on the nominations, but.
No, I don't think a nomination is a second.
No,
I don't think a nomination.
correct. But I will take nominations from the floor if there are any nominations at this time. I will take nominations up through the next meeting in December when we close nominations. Louis, I see you have your,
Yeah, I would like to work on the committee with you, if you don't mind, sir.
wonderful, thank you. Okay, Terry.
David, I would like to nominate you for the first vice chair as we move things up.
Okay. Any other nominations?
I'd like to nominate Terry Hamilton for second vice chair.
Okay, thank you, Steve. Okay, nominations will remain open through when we close them at the meeting in December. And aside from that, that is my report, Mr. Chairman.
Thank you. EMS staff report, Director Greenberg.
Thank you very much. Welcome, everyone, again. So, a lot going on in the Bureau, and going to go through some things here. So on the operations side, in the surveillance investigations, we continue to go out. We are, again, back to or targeting for our 2-year cycle for full service inspection, so being out to most agencies every 2 years. Just a reminder, we use the portal for everything these days. There are different portals, and they're all located on the EMS forms page. That's another question I got just after. Where are they located? They're all located on the EMS forms page. Use the drop-down list depending on what's going on or what you're looking for. The only thing that is getting sent in is the controlled substance check, and that's going directly to the Bureau of Narcotics Enforcement. That's not going to the Bureau of EMS anymore. So you'd fill out your application online, you do everything. There's a printout that happens at the end, or an email that you get, and then you would put the check with that and send that into the Bureau of Narcotics Enforcement. There is a self-assessment tool that is now part of our full-service inspection. It happens prior to the inspection actually occurring, and I'm going to ask Chief Major to step up and just talk about that briefly so that agencies have a little bit more of an understanding. I also, as regional members, want to remind that we are going to work towards having a lot of this information that's gathered in the self-assessment available to the regions, so the regions have, again, more insight of what's happening with their individual agencies and possibly different initiatives that they would like to do based on the information that they're finding. We have made the self-assessment available for anybody who is here and would like to see it ahead of time. I believe there's a QR code over on the table. Chief Major will probably speak on that one. You can scan it. We ask you, please don't submit that button. Please don't hit submit, because that way we don't have a lot of test data that's in there. So feel free to look at it. It's one page. You can swipe right down on that one. Thanks so much. Chief Major?
Thank you, Director. Good afternoon, everyone. The Certified EMS Agency Self-Assessment, it takes sort of a comprehensive 360-degree view of EMS agency activities, from EMS sustainability, data metrics, public engagement, from the perspective of formal policies and procedures and standards, any additional things such as quality improvement activities, medical director involvement, how active the medical director is involved in the quality of care and the quality metrics. Also, it analyzes from your recruitment and retention procedures, your individual community involvement and sort of peer activities. And we're looking to, again, use this as a sort of a self-assessment. And it also looks at strengths, weaknesses, and sort of opportunities as to what futuristically the EMS agency sustainability is related to funding sources, what their ability to exactly staff based on their call volume and some other activities. We are going to share this reporting We've got a small quantity that have actually responded to at this point, but over the next 2 years, as we get into the cycle, we'll continually adapt and modify this particular self-assessment to gain useful data, and we'll share that with SEMAC and SEMSCO. So, Director, I don't think I have anything further.
Thank you. Any questions for Chief Major related to self-assessment? Again, the big thing on this group, and as you take this back to your regional councils, is to understand that that's out there. You might get questions. This isn't something I've seen before. What happens from it? Why are they asking these questions? Is there, what happens if we aren't compliant on something on this? And this is not about, this is about sustainability, not as much about regulatory. There's an SOD that's going to be issued. These questions, as you see them, more ask, how active is your medical director? Like you said, community engagement, things of that nature that we have seen. So really excited about that one. I don't know if you mentioned or not, but we're about, I think about 60 agencies have completed this. Some of the data is where we expected it to be. Some of the data is pretty interesting in opportunities, and hopefully we'll be able to bring that data back to this council as well to be able to look at future projects and tags and things. Not that you're doing enough, Mike, right now, but, one more thing, but these are the ways to hopefully be able to be a resource to the EMS community. On the administration side, we are working on completing some more contracts and making payments. Just a reminder for our SEMSCOs and our program agencies and anybody who's sending things in order for us to make timely payments, we need all the information that is required at the time of payment. So please make sure to send everything that's required. We are returning some information if if the packet isn't complete. Education. So we are really excited and with the work of the Finance Committee and Steve Kroll and his group and Don Hudson, who made some recommendations to me, that there is another update to the EMT training funding page. And that policy is now up live. It's on our website. It's located, I believe it's listed as 2309B. And it is up there with 2309. And the reason that they are both up there is it goes into effect for classes that end after September 30th. So it will go into effect in October. So they're both there so that you can see the two different payment models and things of that nature. This shows an increase, and the biggest increase is in the EMT training. And the EMT training goes up to $950 for reimbursement. And so if we remember back, just a short while ago, we were close to 700, and now we're up to 950 for that EMT training. This is a pretty significant impact. We're really excited about that. We hope it will help our core sponsors and to be able to train more people and be able to provide newer equipment and all these things that go along with it. So excited to see that one there. There's some other minor changes, particularly on the PSC side and reimbursement on that, so please make sure to look at that. And again, that's for classes that end of course date after September 30th. Recruitment and retention. So two things on this one. There is a new pilot program, so the other policy statement that has been updated on there adds a fifth pilot program on. If you remember correctly from the last meeting, the new pilot programs for this year are the EMC Academy, the EMS Agency Internship Program, the Intro to Paramedicine Program, and the Leadership Training, both offering opportunities for payment models in those. And the newest one is the new recruitment and retention model. And so this is after some feedback after the last council meeting where a lot of the questions that come up is, well, they became a certified EMT, but they never worked on a truck. And so how did that really help us? We got another provider, but if they didn't go and work on a truck, how is that helping us? And so this particular model allows people who paid for their own training, they came and said, hey, I want to go become an EMT, I'm going to pay for myself to go for that training, to recoup some of the costs of that training. And so if they go and they work for an agency for a 12-month period of time, that agency can then submit for the costs of their training. Our system does show us if it's been paid out beforehand, so we'd know if they didn't actually pay for their training and someone was to submit, we would see it in our system. But if they did pay on their own and they didn't receive reimbursement for it, they'd be able to get reimbursement for that one after a year of service, either volunteer or career. So again, another opportunity to hopefully make it attractive for an agency who brings on a new employee who paid for their own training on their own. From a staffing side, we're really excited in the education world to bring on Kevin Lynch. He is one of our new unit chiefs. He is out of the Metropolitan Area Regional Office, and he is both a paramedic and an ALS CIC. He is currently working right now on reciprocity applications as well as PSI testing issues. So his day is full with a lot of that. There is also 2 new support staff members who are joining our team starting tomorrow. They'll be located out of the central office but working under education. We are also excited to say that we'll be posting the grade 18 unit chief position that John McMillan used to fill, and so that will be another seat that will be open in education. So if there's people who you think are interested in joining state service, hopefully there'll be another opportunity for them to apply and come join our team. There is a cost increase with PSI. So there was a cost increase. The testing has moved up from $28 to $31. That was effective September 1st. And if you have vouchers or things of that nature that were purchased prior to, those will be honored at what they were purchased at. We know that there's been some issues with PSI. We continue to monitor those. Just in general, we have about 1,000 issues or complaints a year, or issues that we have to deal with. Some of those are directly related to PSI. Some of those are related to providers not knowing certain information in order to be able to get into the testing application or to be able to schedule calls. It's important that if you do have an issue that you let us know. If you get to a testing center, or if you have a problem that comes up, please let us know so that we can track it and put it into our system and make sure to address it as it goes on. PSI is also going through an upgrade in late September with their software system. Reality is, in new technology, we expect there'll be probably a couple of speed bumps along the way in that one. Again, if you have problems, we are here to help you. Kevin is here to help you. Anybody who's having issues with the portal or with anything related to PSI can email ems.testingissues@health.ny.gov. So please feel free to reach out to us and Kevin, and we will move forward on that one. In addition, the testing results that come in are normally uploaded 2 to 3 times a week. So if you've taken your test and it's past 10 days after, you should see that on the Health Commerce system. If for some reason you're not, please let us know. We want to make sure that all the files are getting in there and uploaded appropriately. There have been some situations to where the file hasn't uploaded correctly and then it doesn't show on the Health Commerce system, and we want to make sure that that's out there for you. The big one with education is also our transparency and what is our new ability to show everybody where we are in timelines. So on the EMS forms page, so if you go to the Bureau of EMS page and you go to EMS forms and you click on education, certification, or education, either one of the education tabs, you will see a matrix there. The matrix will show the task that's being done, our average time for processing, and our current time for processing. You will notice some of them are less than our average times, some of them are more than our average times. The important part here is we want that transparency to be there. So if a student, an agency, an instructor is trying to figure out, should I make a phone call? Why hasn't this come yet? They'll be able to go there and directly look. Please also make sure to look at the date that's at the bottom of that graph. It will show you when it was last updated to make sure that in all fairness, that we've updated it in a timely manner and that you're looking at relevant information that's there. Data and informatics, the biggest thing in that one that actually came out of this meeting was a great discussion that came out yesterday related to NEMSIS 3.5. Currently today in the EPCR platform, we have about 900 rules that a provider has to follow in order to complete a chart. In 3.5, we will drop down to almost 250, I think it is, so we'll see a pretty significant change. We were trying to figure out the best way to transition to that, and we were going to go to a standard in between in order to reduce and help people in charting. However, from discussions yesterday, we're actually going to move forward directly to 3.5, and we're going to release that standard in the first couple of weeks of November, and then for implementation between January and July. That would be up to the individual agencies and their EPCR vendors that they use, but they must be compliant and online with 3.5 NEMSIS standards no later than July 1st. So be watching for more on that information. In the world of trauma, STAC meets at the second week in October. They had a pretty major thing happen last week, which is their 405 regulations had a emergency reg change in order to adopt the new American College of Surgeons Gray Book. Happy to see that process through and went without a problem. Our EMS for Children, I will actually, nope, he's not here, he might have left. Our EMS for Children meeting, Our next one is in December, the first week in December. It'll be right here at the Hilton Garden Inn. They are also, the group is working on some pediatric education. Working group is working on producing some videos and education related to dealing with children in those situations, as well as there's a pediatric stroke group that's gathering information on pediatric strokes. We also had some grants carryover, so we're excited to be running some new programs on that one, and we're rolling out the pediatric preparedness program, PEC program, for emergency departments, and more information is coming out on that one as well. Vital Signs, we'll talk a little bit more about that later, but Vital Signs is coming up right around the corner, and there's a specific PEDS track on certain days, including safe transport, de-escalation, communication, as well as disaster planning. And the EMS4C program continues to support different Vital Signs Academy online classes for those who are looking for pediatric education. Vital Signs is October 18th to 22nd in Syracuse, New York. Hotel block is ending very soon. Next week, it sounds like I got the answer this time. It's ending next week, so if you're thinking of joining us, please, and we'd love to see everybody there, please make sure to get online to register and to book your hotels. Just a reminder for a lot of those providers that are out there, can't believe it, but those COVID extensions, the 1 and 2 year extensions, they're coming up. It's time to get your CME. And this is also the reason we've seen a significant spike in the number of duplicate card requests that we've gotten as people try and figure out, when do I expire? So if you need that CME and you're the type of person that doesn't necessarily want to go to online for your education, you're looking for that in-person opportunity, Vital Signs Conference in Syracuse this year is an excellent opportunity. Related to regulation, so we were hoping to have the education regulations here for an emergency approval. Unfortunately, just timing-wise, that did not occur. That also means that this might occur between this meeting and the December meeting. So we might see an additional SEMSCO meeting this year for a specific purpose in order to approve those emergency regulations. Those emergency regulations for education work a lot to bring back into effect things that we saw worked well with EO4. So as we look at that, hopefully we'll have more information next week or two on those regulations. In addition, the equipment regs are in that final standard, final approval process. They won't come to the council first. They will go directly out for public comment because they're not going through the emergency regulation process. So they'll go out for public comment. Once they're out, please, everybody, take a look at them, see, provide your feedback, including use support. Simple things like that can go a long way. The Rural Health Task Force has a meeting tomorrow. They're making a lot of progress going here. I know I see a number of our members around the room. And actually, those who are on the Rural Health Task Force, can you just raise your hands for a second? A couple of them. Excellent. So if you see any of those hands raised, one which didn't, but don't worry, Dean. Please feel free to go up to him and talk to him about your ideas on rural health. There is a survey that's out on our survey page, on the EMS Forms page. They're looking for your feedback, but if you find it better to talk to them in person and give your insight on how you think things need to be improved, I encourage you to go talk to any of those Rural Health Ambulance Task Force members. Speaking of surveys, we've seen a lot of surveys come out lately. And currently today we have 4 surveys that are open right now for feedback from the EMS community. And so for everybody who's watching online, for the nice Vera newsletter that goes out and gives an amazing summary of everything that happens here, we want people to have their voice. We want people to voice their opinions, their feedback on many different things. So currently today, we tried to make sure that all of our surveys are available in one location in addition to going out by email. So on the Bureau of EMS webpage, under the EMS Forms page, under the drop-down that says EMS Provider Surveys and Feedback Forms, you can go into there, and any survey that we have open that we're working on general public feedback on is there. And we encourage you to share it. We encourage you to go there. Each of the surveys are probably 8 to 10 minutes in length, some shorter, some maybe take a few minutes longer. But this is how you can get your voice heard. This is how you can have your opinions out there. Currently today we have surveys out for diversity. We have surveys out for the salary surveys on there. The Rural Health Ambulance Task Force has what they think are some solutions on there, and they want your feedback. They want to hear, are they going in the right direction, or do you have other ideas that are there? As well as feedback from things from Part S. So all these are out there. We encourage you, please go to those pages, take a few minutes and fill out a survey or two. And just want to thank everybody for taking that time. We know everybody's schedules are busy, but this is a critical way to help us move forward. New staff within the Bureau. We're excited to have some new staff. We spoke about Kevin, who's on our education side. We have new staff members on the Vital Signs Conference. Little sad to say, we have Jacob, who has been with our EMS for Children. And actually, Jacob started as an intern with us many years ago as with a college intern, and then turned into a position in our data and informatics unit, and then a full-time position with our EMS for Children. He's leaving for a wonderful opportunity, and we're excited for him, but big shoes to fill. He's really done amazing things behind the scene, and just want to thank him for his service and his time that he's been with us. Also on the new staff side, we have another opportunity that, again, as we talk about creating opportunities to help advance, professionally and different things. Gina, who is one of our policy fellows up until recently, has just been hired as one of the newest district chief investigators. And so, again, excellent opportunities. And I encourage people to look within their own organizations and to figure out how can you create opportunities in your organizations. Can you create an internship? Can you have a fellowship? Can you have things that are going to yield advancement of a career? I think Mike will probably talk about it later with our salary survey. 75% of those 3,500 people who responded to the salary survey turned and said that advancement opportunities or a lack of advancement opportunities are some of the biggest frustrations that they have in our profession. And we can do something about that. We can create those opportunities to advance, but they take work and they take effort, and we need to do that together. Last, or second to last thing, I guess you would say, is Part S. Just want to give a little bit of update on Part S as we're moving forward on things. The State EMS Task Force working on putting together a very small framework that then will go to a larger development of it. But the biggest thing on the State EMS Task Force and the funding that's behind it is working on putting together contracts for ambulance services to be able to pay for readiness, so that when a disaster happens, when something happens, that we can be able to immediately respond and be able to have those contracts in place to be able to pay for readiness. And so that's a big one. We're working on that for around the state. We're looking, most likely we'll have about 50 ambulances around the state that would participate in that portion of that readiness. Between now and December, we're hoping to have more information on that to be able to start that process where agencies would be able to apply to be one of those ambulance services that would provide an ambulance. So again, very excited on that front and moving things forward. The system and agency performance standards that were in Part S last year, I know there's been a lot of work about that one. Mike got invited to a lot of meetings over the summer. This is really exciting stuff. This is new legislation. We haven't had new legislation since almost the 1990s, I believe it was. There's a lot of different input that's going on. Thank you to everybody around the room who's also part of these committees as we move forward and move these ideas and suggestions into regulation as it moves forward. We are moving forward on a mental health and well-being program. We're looking at 2 different programs right now to hopefully roll out, and I'll have more information about that one in December. And then our recruitment and retention one. We very intentionally split the recruitment and retention into 2 different objectives. One will be a statewide initiative to be able to do recruitment and retention from a statewide side of things. The second is a regional approach. We know the regions are each a little bit different in how they approach things or what the dynamics are in their region. And so we are working right now, and again, hopefully we'll have information before next meeting because we want to get this out as soon as possible, to have, I believe it will probably be somewhere in that $10,000 to $15,000 per region for a region to do their own recruitment and retention program. To be able, maybe that's a website redesign, maybe that's a marketing materials, maybe it's whatever the region decides that it wants to be. Hopefully there will be 18 different ideas and concepts. Each will, be able to be tried in a different way. And then we can see what worked well, what worked the best, what we were able to yield out of that as a final thing. So again, a lot of really good things going on, the funding behind it to do it, and moving things forward in a positive way. Just want to say thank you again to everybody who's working on all these other groups and tags and things that are happening. EMS is absolutely in the forefront in many different ways. And, just want to say, thank you for all that. With that, I'm going to pause for a second and go over to Deputy Commissioner Morley, who is joining us today, and see if he has any other comments.
I don't have anything to bring to you, but I'm more than happy if somebody has questions or issues or concerns or something to hear from you folks. Now or during breaks or afterwards. Going once? Going twice? Sold.
Any questions for the director or deputy commissioner?
Chad Smith, I just have a quick question on the 3.5 schematron. You said it'll be sent out November first couple of weeks for agencies to start sending in January 1st. Can they start before January 1st if their PCR vendors are ready or no?
I don't think they'll be able to start before January 1st. So we actually have an entire policy based on a new schematron. So again, feedback that we hear on a regular basis is, well, there's too many schematron updates and things like that. So we put together a schematron policy update, which would say we're going to release every January and it's going to go into effect every July. By the way, that also aligns with our protocol update policy that is going to release every January to go into effect every July. So there's always enough time for training and transition and things of that nature. In this one particular case, as we move towards 3.5, because we're trying to get there, I don't want to say faster, but without an in-between. The standard, which was going to be released on January to go in effect in July, we decided to release in November to go into effect anytime between January 1st and July 1st.
Okay, so no longer accepting 3.4 after July 1st?
Correct, after July 1st. There'll be a period of time where we'll take 3.4 or 3.5, but after July 1st, it will only be 3.5.
And to clarify, we're in New York State, that is 2024. Any other questions? If not, I will move to the physicians for the SEMAC report.
Okay, well, we're going to go over to med standards with Dr. Marshall. He had 2 second motions to be voted on.
Thank you, Dr. Doynow. Good afternoon, everybody. Medical standards met this morning, and SEMAC met earlier today before this meeting. And we have 2 motions for your consideration. The first one is the collaborative ALS protocol update. And the protocol update simplified some language, reduced some inconsistencies, and made it easier to use without changing the medicine. In addition to that, there were quite a few changes which you had the opportunity to go through. 2 items to bring to your attention is the anaphylaxis protocol was changed to allergic reaction and anaphylaxis, which would enable ALS providers to administer Benadryl or steroids to patients not in anaphylaxis but with allergic symptoms. And they're going to put in a clarification on some examples of what they mean by that. The other item within the changes that was removed was a CFR administering glucose because it is not within the scope of their practice. So the other thing that the collaborative did was make sure that the protocols match the scope of practice for the different levels. And that comes forwarded as a second in motion.
So any discussion on that motion? If not, we can have a roll call vote.
Stephen Katie.
Steve Katie, aye.
I'm sorry, what was that? Yes. Steve Katie, yes.
He said aye, which
Steve
is...
Katie, yes, I'm sorry. Aye, yes.
I'm sorry. Scott Clark.
Scott Clark, yes.
Mark Devers.
Yes.
Don Duval.
Duval, yes.
Mickey Fornes.
Mickey Fornes, yes.
Carl Gandolfo.
Carl Gandolfo, affirmative.
Gregory Gill.
Gregor Gill, yes.
Jason Haig.
Jason Haig, yes.
Teresa Hamilton,
Yes.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Isaacs, yes.
Al Kim,
Yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Jared Cutson, yes.
Al Lewis,
Al Lewis is yes.
William Masterton,
William Maston, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
McGowan, yes.
Mark Philippi,
Philippi, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
Simmons, yes.
Carla Simpson,
Kyla Simpson, yes.
Christopher Smith,
Smith, yes.
Chad Smith,
Chad Smith, yes.
and David Violante.
David Violante, yes.
Motion passes.
Okay, the second item to come forward to this committee is, if you recall, Policy 1304 was an alternative medication formulary that we developed many years ago. These shortages continue to this day, and they can vary by the state or by region. So we've revised the alternative medication formulary policy, which will allow for regions to activate their alternative medications as needed based upon the regional needs, as well as the state. This policy also will require notification to the department on implementation of alternative medication, every 3 months review of the need to continue, and then notification to the department upon termination of the alternative medication. The other part of this is that in the old policy, the medication formulary was actually part of the policy, and so that will be pulled out separately, and it will be in an appendix. That way we won't have to change the policy with every alternative medication we need. But I do want to thank the team that worked on this, Dr. Winslow and his team, for putting this together, and that comes forward as a seconded motion.
Any discussion on that motion? If not, could we have a roll call vote?
Steve Cady,
Steve Katie, yes.
Scott Clark,
Scott Clark, yes.
Mark Devers,
Yeah.
Don Duval,
Duval, yes.
Michelle Fornes,
Mickey Fornes, yes.
Carl Gandolfo,
Carl Gandolfo.
Gregory Gill,
Greg Gill, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Isaacs, yes.
Al Kim,
Yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Cutson, yes.
Al Lewis, William Masterton,
William Maston, yes.
Michael McAvoy,
McAvoy, yes.
Elizabeth McGowan,
McGowan, yes.
Mark Philippi,
Philippi, yes.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Kyla Simpson, yes.
Christopher Smith,
Chris Smith, yes.
Chad Smith,
Chad Smith, yes.
and David Violante.
Violante, yes.
Motion passes.
Thank you.
There's one more seconded motion. This one comes from Education Committee, and it was removal of the PSC exam for paramedics. Don Hudson, I don't know if you want to describe what you folks came up with.
So yes, thank you, Dr. Doyle. So the National Registry in 2024 is going to be sunsetting and eliminating their practical skills exam. That practical skills exam, in some way, shape, and form, has served as New York State's practical skills exam for the paramedic original level for many years. So to continue to strive to align New York State with not only the National Registry, but the nation as a whole, there's an opportunity here for the paramedic original, sunset and match the National Registry's sunsetting of our practical skills exam. Now, this is complementary to the regulatory changes that have been submitted. We just wanted to be ready for them when they come, as, 2024 will be here before we know it. So, again, it's just for paramedic original at this point. There's counter discussions to other levels and whatnot that will be had down the road, but one has nothing to do with the other at this point.
Do you want to read that motion? I can't see it from here.
I was going to say, maybe you can try. Read the lowest line that you can.
New York State Department of
Okay.
Health.
Well, okay, we'll recheck your prescription. So the motion is to recommend to SEMSCO to eliminate the paramedic practical skills exam by July of 2024.
Any discussion on the motion? If not, I would entertain a roll call vote on this.
Hold on a second.
Go ahead, Don.
As read, motion to recommend to SEMSCO. As we are SEMSCO, should we be rolling that recommendation to the Bureau or to the Commissioner?
I would say it would be proper just to eliminate to whom and just leave it to everyone. But I guess the question goes to Ryan, in conjunction with the pending regulatory anticipated changes, what do we do here? We don't want to mess it up in some way, shape, and form or muddy the waters to delay it.
Well, originally, yeah, so there's a wording issue here. Originally, this went to SEMAC from T&E and was designed for them to recommend to us, but now it's here in front of us in the same wording. So I think if we took the SEMSCO out of that, then we would have what we need. And the point of this really is, between now and December, if these emergency regs actually come through, then we have this piece so that we can begin implementation of it. Absent this action, we would then have to wait until the December meeting, should the regs come into play prior to that. So that's the point of this, basically. So I think if we take the word SEMSCO out of there and say just recommend.
Yeah, as training and education, I would agree, take SEMSCO out.
So let's take a motion from the floor to make that motion.
Yeah, just a question on it, Mike. We're not recommending. That was the motion for the earlier in the day. So technically, it should be to eliminate.
So I think it's still a recommendation.
Yeah, it comes from this body and has to go to the Bureau of the Commissioner and then can get done by them, but we do recommend it.
Yeah, but we're recommending to ourselves. We're voting on a motion to recommend to ourselves. I'm saying it just got to be wordsmith. To recommend the removal of it's fine, but not to recommend to SEMSCO.
I would move.
I'll make the motion. Recommend to eliminate the paramedic practical skills exam by July 2024.
Thank you.
Sounds good. Any discussion on that motion?
That's got to be seconded, right? Second the amendment?
Say that again? Oh, yeah, a second.
Yes.
You want to second it?
We should second the amendment to the motion.
Are you seconding it?
Sure.
Okay, so we have a second. Now, any discussion on this motion, since the first one was out of order?
Did
We
that
can't-
motion state just the original class? I missed that if you did.
Thank you.
Because the recommendation from education and to CMAC was for original courses only.
I thought we were leaving that open because there could be discussion that if we made it too specific, that we couldn't move in certain directions if we needed to.
I will say that I think you should, I think sticking to the original for this particular time period is the right recommendation. There's a lot of other things that Don will have to work on, keyword on Don will have to work on, in order to, he can't turn around and talk to Drew. No, that we'll need to figure out. Again, even just some of the things that we brought up in the last meeting, which is if it's a recertification, what if the person hasn't been practicing? What would the portfolio be? Remember, when we move towards eliminating the PSC, it's not removing the evaluation of a person's skills and assessment and ability to do a job. It's reviewing, it's elimination of doing it all on one day in a terminal exam or testing environment. So for a paramedic original course, they are creating a portfolio of that skill set over the period of time of that course. For a refresher course, that doesn't exist today. And so we're not saying that we can't get there, can't figure it out, but I think there's a significant amount of work that will need to be put into place in order to incorporate that and move towards that determination.
Okay, I would like to amend my motion to read, recommend to eliminate the paramedic original practical skills exam by July 2024.
Do you amend your second?
Sure.
Okay. We have any more discussion about that? If not, we would require a roll call vote for this.
Steve Katie,
Steve Katie, yes.
Scott Clark,
Scott Clark, yes.
Mark Devers,
Yes.
Don Duval,
Sure.
Mickey Fornes,
Yes.
Carl Gandolfo, Gregory Gill,
Regular, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Don Hudson,
Don Hudson, yes.
Dr. Isaacs,
Isaacs, yes.
Al Kim,
Yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Hudson, yes.
Al Lewis, William Masterton,
William Maston, yes.
Mike McAvoy,
McAvoy, yes.
Elizabeth McGowan,
McGowan, yes.
Mark Philippi,
Philippi, yes.
Dr. Raybrich,
Raybrich, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Carlos Simpson, yes.
Christopher Smith,
Chris Smith, yes.
Chad Smith,
Chad Smith, yes.
and David Violante.
Violante, yes.
Motion passes.
Motion passes. Doctor?
Okay, thank you. Since most of you are here, we'll do the Cliff Note version of the rest of the meeting. Dr. McAvoy spoke a little bit about credentialing, which I believe he will do at this meeting of providers. We had a very interesting presentation by Dr. Jennifer Goldman on crisis stabilization centers that are going up through the state. More to follow as more of these are put into place. And we believe she probably will be joining SEMAC as our psychiatrist, which we've never had before, which is fantastic. Other than that, nothing else really to add on SEMAC.
Very good. And I believe that Med Standards probably exceeded any record ever with a 28-minute meeting this morning, largely due to the collaborative group, Dr. Cushman and his colleagues on the collaborative protocol group putting together 46 protocol changes into one very long effort over the summer to get that done. So it shows that working between meetings can get a lot of work done. So any questions for Med Standards or SEMAC? If not, we'll move on to executive. And I want to remind people that there are 9 committees that work with SEMSCO. Well, there are 10 actually, 1 is executive, but 9 committees where people could join. And we've had a number of people come to me and say, I want to be on a committee. You don't necessarily need to be on SEMSCO to be on a committee. So the committees are growing and becoming more productive. I really congratulate every single one of the committees that has worked over the summer. yeoman's job has been done on performance standards. And I want to briefly talk about that because we now have, and I posted those of them that could be posted on Boardable, but we basically have 11 performance standards that were submitted by 4 committees. The committees on safety, training and ed, quality, and one other, systems, put together some performance standards. And I want to quick run through these. There is a great deal of complexity to the way, if you read through them, that they came from the committee. So there's a definite need to form a work group to take all 11 of these, put them into some format that can be digested by this body in December. And from those 11, or whatever this committee synthesizes them down to, I think we should probably pick 4 of them to move on to regulation as actual performance standards, as we were charged to do in the governor's budget legislation that passed this previous year. So of those metrics that you saw, the Quality Metrics Committee came up with 2 that they suggested. The first was each agency will identify 3 QI measures that they will choose from the state-approved measures, which we approved at our last meeting. The second is that each agency will identify a quality coordinator and demonstrate how they do QI to their region. The Safety Committee came up with 2. The first is to publicly report employee injuries that occur each year. The second is to publicly report vehicle incidents that occur each year. The Training and Ed Committee came up with 3 recommendations for performance measures. And the first of those was to develop performance standards for EMS education that basically changed the asynchronous, synchronous percentages of way that education is done in state courses. The second is requiring degrees for EMS providers. And the third is to report EMS class retention rates and to set some metrics for course sponsors to have certain retention rates. The Systems Committee, which I'm not allowed to say, but I will, submitted 4 performance measures, and the first of those was to implement stepped response requirements. In other words, over a course of several years, agencies would be required to answer a certain percentage, escalating each year, of their emergency calls. The second is that agencies would publicly report and disclose response and staffing data of their agency. The third is to require PSAPs to engage with their REMSCO in order to assure that the closest ambulance is dispatched to each call. And then the fourth is a whole set of a template of standards for dispatch and for response. And it basically sets definitions and standards for each one of those. So that's the 11 that we have. And I will seek between now and December to put together a work group, which I have voluntold Mark Philippi that he will chair, since he's the previous SEMSCO chair, last chair who survived a term as chair of SEMSCO. And that group will then take these 11 standards, synthesize them, and come back to us in December with some things that are actually measurable. And I'll write up a charge for them. You know, the 2 questions really are, how can we translate these into measurable things, practical things, and also things that we know who they apply to. Because in our original charge from the governor, it said we would apply things to regions, to agencies, and to dispatch centers. So not all of these obviously apply to each one of those. So I would say, rather than having everyone at the table raise their hands, which I know all of you are itching to do, if you contact me, we'll assemble a group and put that together within the next week or so. If you have others that are not sitting at the table here who would like to participate, they are certainly welcome to join. So that's the first piece of, and I think the last piece of the executive committee.
Excuse me, Mike?
Go ahead.
Will that be people outside of the table as well? to
Could be,
on that
yeah.
committee?
Anyone,
Okay.
yeah. You don't have to be a SEMSCO member. You could be sitting in the audience here. You could be the housekeeper that's waiting outside to see what we leave behind. It could be anyone, yeah. The next committee is Education and Training. Don, do you want to talk some more about what went on at that meeting?
Boy, do I. So Education and Training met as per the norm, and I'll give an abridged report since a lot of it is redundant from the report given at SEMAC. So that being said, we have a number of open items that we're looking at, and as always, we bring it here for people's awareness and, more importantly, your involvement, as we need all stakeholders' input to make good decisions and then monitor that they're actually having the intended impact. So just from the Bureau's perspective, again, the aforementioned problems with PSI and the raise to $31, just for everyone's awareness to reiterate that. The Bureau also acknowledges and will be meeting with PSI over the course of literally the next few days to try and iron out some of PSI's problems as far as feedback, HCS, updating, how that's impacting the printing of cards and the backlog there. So thank you to the Bureau and, more importantly, Mike Boghossian and Drew Chesney for their continued efforts to try and right this ship. What we have coming down the pike is, alternative funding for course sponsorships. As we said, there's a new policy released literally today to continue to up the state funding allotted to course sponsorships for various EMT levels, or EMS levels, rather. We're looking at alternative pathways for funding, whether it be through collegiate affiliations or other monies out there, grants and otherwise. Instructor certification, so the committee is looking at continued revamping and forwarding of the concepts of lab instructors, instructor coordinators, and then probably most groundbreaking is our cross-profession reciprocity, if you will, for teachers who might have education degrees, the fire service, police agencies, other healthcare, allied healthcare that have some sort of teaching certification, and how they could potentially help us and teach EMS and get EMS certification, teaching certification out of that, and what that door would swing the other way for us to look at as we continue to build out the EMS profession. There's a policy being worked on collaboratively with the Bureau staff for the co-requisites required for EMS training classes, not only particularly for hazmat, but also trying to roll in the co-requisites for CPR and incident management system training into one policy rather than having people hunting around looking for different policies to try and find out what's required. Also, looking at field training officer or mentorship program, what that should look like from the state level on down. So to all agencies, or really anybody, if you have a functioning and well put together mentorship or field training officer program that you'd like to share, we're not above theft, especially if it's a good idea. So if we can share that information, that would be great. At least we reinvent the wheel. Also, inter-facility certifications, looking at those doing particularly critical care, paramedic level, or that high-level ALS interfacility transports, if the state would like to dip its toe into what certifications are out there, what they should look like, what those standards within New York State should be. So again, nothing imminent, but just discussion points and hopefully some future fruit to bear from that. Two last things. So any persons having problems with PSI or any of the scheduling for testing, please utilize the Bureau's email address for testing issues. That's ems.testingissues@health.ny.gov. That would allow the Bureau to not only track these, but chase them down and see if there's any trends that develop when they do meet and continue to push PSI for better improvement. And then lastly is our ongoing discussion, which I'm sure will only intensify in the recent and coming months, regarding the EMT-CC to paramedic bridge. So without getting down in the weeds on that at this meeting, just to give everyone a sense. So obviously, as people have bridged and life goes on, the number of CCs within the state is dwindling as anticipated, part of the plan for sunset. So the status of the current bridge program is there's 2 active cohorts. The first cohort statewide has 21 providers in it. The second cohort, still active, statewide has 21 providers in it. And the next cohort, slated to begin in October, statewide has 4. So the bridge numbers, too, are dwindling, and that's part of the discussion about if and when this ever truly comes to an end, what's the time frame, what's needed operationally, medically, and how should that look? So that's the discussion, and that's the goal. Again, it's a discussion. Please don't say that Ryan Greenberg killed the CCs at the December meeting.
Any questions for training and education? If not, we'll move on to finance. Steve?
Good afternoon, everybody. 2 things we're working on at the Finance Committee. The first one, I think Ryan already gave you the bottom line, which is the joint program between the Education Committee and Finance Committee yielded enough data for the Bureau to increase the rates and that for course reimbursement, and it's already published. Ryan mentioned the original for EMT and AEMT are going up to $950. And there was a lot of discussion in this committee about the growth of AEMT, especially in rural communities, and how it could be very valuable. The refresher rates for both of those are going up as well, and the PSE exams going up to 100, 200 for paramedic. So we began this recognizing that we were not spending the entire Bureau training budget, yet we kept saying, well, can we get more money? And the answer to that was, well, you kind of have to spend the money you have in your budget before you can go back to New York State and say, we need more money for training. So the rates, so the EMT original is up 38% during this calendar year. The AEMT original is up 80% in this calendar year. We are certainly going to see course sponsors who say, well, it still costs me more to put on the course, but we've made some really big progress. And so I want to encourage everyone to make sure the course sponsors in their regions see this as an opportunity. We do have the academy classes going on, and if you remember at the May meeting when Ryan announced the 4 pilot programs, one of them was that each course sponsor could do an academy-style class, meaning that it would be fully reimbursed at cost during the next year. We only have 3 academy-style classes. Only 3 course sponsors have taken up that mantle and have those courses currently running. So I want to remind everybody that any course sponsor can come to the Bureau, ask to do an academy-style class. It'll be fully reimbursed, and the length of time for an academy-style class has been significantly lengthened. You know, we can go. It doesn't have to be as intense. There's time for testing and skills exams after the course time. So please take a look at that. Ultimately, we would like to be in a position that when the next budget cycle comes up, Ryan can tell us that we've spent all our money on EMT training, and we certainly need more EMTs, and so that'll lead me into the second part of the conversation. We released at the May meeting a survey, or we completed the work on a survey at the May meeting, and I want to thank Donna Camp. I'm not sure where Donna's sitting, but Donna was a really big help on putting that survey together with the Finance Committee on looking for salary information, and we got 3,831 respondents since May, and we've completed our first round of the analysis of the survey. And SEMSCO members should have the slides that were prepared by the Bureau Analytics staff. Alex, I think, led that work. You should have received that on Boardable. And last night, I put out an executive summary of the results. I'm going to highlight just a couple of things. First, by getting almost 4,000 responses, we got a return rate of more than 10% of the active EMS responders in New York State. That's, Ryan has mentioned, of all the surveys he's put out, that may be one of the better response rates. So we've got some valid data here. Alarmingly, 37% of the respondents said they plan to leave the EMS field in the next 5 years. That highlights the pressing challenge we have. Only 48% of respondents believe that they have a long-term career in EMS. 27.5% said no, and 24.5% said they were unsure. We have this data broken out by region, and some of that is in the slides. Some of that can be broken out by crosstabs. So this data has now been released. Regional representatives, you can go back to your region, and if the slides don't have what you want by region, you can contact the Bureau, and they'll run the analytics for your region. But when we saw that, we've seen several regions where we see much more negative numbers and several regions where we see positive numbers. So the 37.5 respondents planning to leave the MS field in 5 years, it's not uniform throughout the state. You can see how that looks in your region. We have wage data in there, and you all should have that summary, so I'm not going to read the whole summary to you. But we have got, we picked some marker points. For example, 45% of EMTs reported having an hourly base wage of $19 or less. You can all talk about in your market whether $19 is a good wage or not, but about half of our people earn less than that. Similarly, 35% of paramedics reported having a base wage of $29 an hour or less. 24.5% of the EMTs reported earning less than $39,000 a year. 18% of the paramedics reported earning less than $59,000 a year. So I don't give you those numbers with any value judgment, but now you'll have some information, and we have some information on salaries. And this survey started when the question was asked, everyone says we don't make enough money. How much money should we make? There was also a section on workload, and there was some significant things in there. 73% of respondents reported working more than 40 hours a week. 17.7% reported working more than 61 hours per week. In 5 regions, 25% of the respondents worked more than 61 hours per week. And those are they're both rural and urban regions. So we know that to make a living in this profession from this data, you've got to work more than most people work, more than 40 hours a week. And is a 40-hour work week the right work week, or should it be a 60-hour work week? That's a question that's out there. One of the things that's present in this data, a lot of cross-tabulations could be done. For example, there's some look at not only how much gross wages a person makes in EMS, but also how that relates to how many hours they work. So we can look at someone that works 40 hours and see how much they can make, and we look at how much it works 60 hours and how much they earn. So again, valuable data. 85% of respondents have reported experiencing burnout or compassion fatigue in their role in EMS. And 68% of respondents admitted to considering a transition to a different healthcare career. So those are some highlights. You'll now all have the ability to look at these charts for yourself. You have the ability to ask questions about the charts and maybe do runs of data that are more specific for your purposes, looking at it at a local level or at a regional level. But I think this adds to our growing body of evidence that we have got a challenge in front of us, which is we went from having the number of EMTs in New York State has dropped over the last several years. Ryan released those numbers recently. I think Steve DeZura reviewed those with the Public Health and Planning Council, Planning Committee, and a slideshow that talked about 20% less people getting new certifications as EMTs in New York State in over a 2 or 3 year period. Now we see that of our active responders, a lot of them are planning on perhaps leaving. I made a pitch early this year that we need an all hands on deck push for 10,000 more EMTs in New York State, right? We need to find 10,000 more people that want to become EMTs and paramedics and get them certified, get them working, get them engaged, getting involved. So this data will just speaks more to the challenge that we have in the workforce. And it provides us concrete evidence as we do advocacy in that area. So I'd be glad to answer any questions on the work on the survey, take any comments from the Finance Committee members that help work on it. And again, you've got this stuff in Boardable if you want to look at it. And we're going to have to figure out what to do with it.
Any questions for Finance? If not, prior to systems, I just want to let the Deputy Commissioner talk about the FIPIC meeting. And I guess explain FIPIC to begin with.
Thank you. So I guess I lied earlier. I do have something to say. FIPIC is what we call it, PHHPC, Public Health and Health Planning Council. So it was this body that brought to the attention of that group that there was an impact on public health from some of what's happening in emergency departments and that overflow impact then on EMS. The group has really taken it on with great pleasure. They're deeply, deeply invested in this issue and this topic and concerned about the impact. It's seen and has been, many people have commented that the issue is a microcosm of healthcare. That said, there's also a recognition that this is a huge issue, bigger than what they're capable of. So how do you eat an elephant? One bite at a time. The group has had a work group session related to mental health, and it's my understanding that yesterday there was a presentation from OMH. I hope that that was seen as helpful. OMH has been given $1 billion by this governor, but has been working on issues for the last few years that are now going to be supported and are going to come to fruition. The only unfortunate part is that the workforce issue is probably greatest in the area of mental health. So they won't be able to implement things uniformly across 62 counties, but they will be doing a number of different things that hopefully will help with the issue of ED crowding. And so the work group, first work group, mental health issues. The second work group, you folks are more aware of the data than I am, but 17% of the patients that go in and do not receive true emergency care are dental patients. And as it turns out, this issue that we're looking at is also becoming, many other areas are becoming aware of the problems with dental care, not just in the United States, but in the country. So that's the second thing that they've taken on. We've met with the Dental Association, the work group has, and the Planning Committee is preparing a report that's going to be going to the governor's office. The third presentation, I want to thank Steve and Ryan and a number of other folks that are here in this room for the presentations as it relates to EMS. It's a complex system, so the folks that are members of the committee asked for a presentation, and that was provided by, again, Ryan, Steve, and others, and some of the things that are happening in the EMS community attempting to deal with the issue of ED crowding and the impact then on EMS. So the area, this is an issue that's going to continue for a while, but I think you'll be happy that the folks have recognized the concerns, the impact that it's having, and are attempting to address this and get the attention of others, including the governor's office, on the issue. Trying, and again, it's an elephant, so one bite at a time. There are other bites that will be identified and other bites that will be taken on, but mental health and dental are just the first two. We'd be happy to hear from specific other issues, other bites from this group as to what the Public Health Council can and should be looking at and learning about and then reporting on in their report that will be going to the governor's office. Does anybody have any questions about any of that? Yes.
So thank you. I think these are great steps, and they all help with the inflow to the ER, right, and alleviating those problems.
Yes.
Is the group looking at, down the line perhaps, the outflow from the emergency department, right? The emergency department backs up because there's all these other issues downstream. So I think there's lots of opportunities there as well. While, these initial looks that help offload the inflow are great, I think we have to look at the outflow as well.
What a great question. Yeah, it has been mentioned. and it's more than mentioned. I want to be clear to say it's more than mentioned. It's just we haven't had a work group meeting on that, but that has been identified as another topic for a work group to take on. We agree completely. And, again, you folks are going to be more aware of some of the things that are going on. What we would be looking to do is to support them financially or come up with some mechanism or have payers come up with mechanisms to support those things and to get them, as broadly implemented across the state as we possibly can. So yes, thank you. Anybody else?
An issue that was brought up at our previous meeting, and I'm just looking around the room, the people that brought it up, it looks like they may have already departed at the SEMAC meeting, was the integration of electronic health records between hospitals and EMS. And when you look at the charge of the planning committee's meeting, the FIPIC planning committee, it specifically mentions the adoption of information technology in their committee charge. So I think they might be excited to also work on this. The crux of it, which Dr. Daly presented with Dr. Cushman, was that right now most of the data that is being sucked into hospital medical records from EMS medical records is coming in as flat files and becomes a PDF someplace. And with all the hospital systems around the nation and around the state, whether they're moving to Epic or something else, they're building out pretty robust platforms. And it would be great to have interaction between the hospital community and the EMS community when those foundational projects are starting so that we can integrate these records in usable format. And we're not reinventing the wheel because systems around the country are already doing it. And that way, the data that we have in our patient care report will be not only in the hospital medical record, but will be actionable and integrated in a digital format.
Another great concept. So we did, the department was fortunate to hire a few months ago, I'm going to guess it was 4 or 5 months ago, Drew Hatchett as our new Chief Information Officer within the Department of Health. And he is working with the Shiny folks and with the Rios and with others. And your point is well taken about the obvious advantages to that. I often make this comment that electronic health records today are about where Henry Ford was in 1890. And between the work that the computer folks are doing and the work that's being done with ICD 9, 10, 11, and more to come, the need for the integration of the different systems is increasingly obvious with every passing year. And it's obvious to me that it will have no choice but to be completely and totally integrated down the road. So, I will raise that to Drew Hatchett, our CIO, and you might actually invite him to one of your meetings sometime to, talk about this in further detail. If there are no other questions, I've got another WebEx to attend, so thank you very much.
Does your Siri watch have any parting comments?
Too many comments. I'm looking to cut back on Siri's comments.
All right. We will move to the Systems Committee, Mr. Devers, which had such an enthusiastic meeting yesterday. They met again today.
Yes, we had so much fun that we decided to meet a couple of times. So we'll report and then talk about the motions. I don't believe Doug Sandbrook is still here. I don't know if he wants to come up and talk real quick about the trauma stuff that he did. He put together a PowerPoint and some very generic, non-labeled guidance. That way we didn't really have to get approval from the department or anybody else to put it out to help with education on when to use what trauma hospital selection based off of acuity of patient and geographic location, and he can talk a little bit more about it now that I think he's on his way up. Yep.
You really hit it all. The group met throughout the summer and pretty much met every other week. We had 30 members participating from across New York State representing the trauma systems and EMS agencies. The goal was to develop a resource to share across New York State to provide education on the trauma triage guidelines as they were adopted in February, and we did not provide any education. So the goal was to provide very simple information to be shared freely and willfully without anybody's recognition on it, just to provide to the REMSCOs, to the EMS agencies, or whoever wants to provide the education. We would provide this as a resource for that purpose.
And I'm not real sure. I'll get the resources out to Ryan and the chairman, and they can come up with ways to distribute it probably through the program agencies. The working group that was looking at the wonderful document 0606 is pretty much finished up. They took the monstrosity of a document and cut it down to 20 to 21 pages, depending on how exactly it's formatted. I'm hopeful that that'll come to the December's meeting. They kind of got the final draft in right after the EDCC deadline. But hopefully we'll get rid of some of the garbage that was in the original 0606 and the extra work that didn't really fall into code and regulation, and be able to streamline the process. The chairman already stole my performance standards thunder, and so with that, I have 3 motions, I believe. So
Which one do you want to begin with?
the town of Alden, sorry.
Alden?
Mr. Chair. That was me. I'm sorry.
Go ahead.
Mr. Chair, if I could. Okay. Just prior to we deal with this, I know this is a really hot topic on some things with these CONs. I was able to look at some of the documents on this, but once again, having a very short amount of time to completely digest and hopefully make an educated decision on this, I don't feel I'm comfortable and able to, my personal self. I did talk to some colleagues over the past 2 days, and it's my understanding that this document for either of the 2 CONs for Lancaster have been presented to the Systems Committee at the last meeting, at the May meeting, which I did not attend. Is that correct? And then they got tabled, I understood. However, I looked back in the record. Nothing was brought up at the SEMSCO meeting in May. Nothing was in Boardable that I could find that I could have taken all this time from May to now to look at this. And I'm once again, 900 and some pages, and I had since Friday night to look at, well, actually, I had since Sunday, because I had trouble finding them on Boardable. And I personally don't feel comfortable making a decision on either of those CONs, especially looking at the evidence that was, because we can't add new evidence, and I understand that, with the ALJ's recommendation, which is not even on the same page. If you read this and looked at the ALJ's recommendation, this is an expansion application, and the ALJ makes a recommendation for a muni CON conversion. So to me, I think the ALJ should have to relook at this so we can get an accurate ALJ report. And again, the timeline of the 900 and some pages of having only, theoretically from the email that I received, 96 hours to digest, interpret, and make a decision. And with that, the ALJ was given a request to look at this in March of 22, and their decision and report came back in January of 23. March of 2020. And the ALJ's report came back in January of 23. ALJ had this for 22 months, and I'm supposed to make a decision in 96 hours? That's all I have to say. I'll tell you this, when they come up to vote, I'll be abstaining because I am unable to make an educated and proper responsible decision.
Mr. Devers, your first motion.
So my first motion went away. The first motion is to reverse the decision of the Wyoming Erie REMSCO and grant the CON for the town of Alden. So if you're doing visuals, a yes vote will overturn and grant the CON, and a no vote will uphold the REMSCO's decision and deny the CON.
So the recommendation from Systems is?
The recommendation from the Systems Committee voted yes to overturn and grant the CON.
Any discussion on the seconded motion here?
Mr. Chairman, Mark Philippi, I have some issues similar to what Mr. Cady said, not necessarily in the timeliness issue, because I fortunately did have access to the documents. However, I echo the same concerns that I believe the administrative law judge was under. Again, I don't want to speak for that individual, but it seemed by the record that there was a misapprehension as to how this particular case came about. A misapprehension that I too was under, because again, having to reread it and go through it again to realize this was not actually the conversion of a municipal CON, but a independent and not-for-profit organization expanding operating territory. There was a public hearing held. The REMSCO went through the process of that public hearing. The REMSCO, from all that I read in their record and the vote that they held, expressed many of the concerns I believe all of us around this table have, and that is the continuation of emergency medical service in the town and village of Alden. I don't think anyone here can deny that that is a concern for everyone. What I rise to speak of is the process. We have a process. It is arguably flawed by the number of times that these matters have come before this body for redirection and discussion. We're working on that. Mr. Devers and his team diligently working to revise Policy 0606 to give EMS agencies and REMSCOs guidance. We know that this was an issue, and the fact that it came up through the governor's budget and discussion of how we could change the processes of the CON revisions and CON granting and so on. My concern here is not whether or not there should be service, it's how that service is delineated. This seems to me, in this particular instance, as an end run around the process. We have municipal CON, and we have expansion of operating territory. And those are distinct processes. If the town of Alden wishes to have the Lancaster Voluntary Ambulance provide service, they can contract with them. That is within their right to do if they have a municipal CON. So I'm not sure what we're doing here to try to get to the point that we all agree should be, that is providing service in this community. I don't support the idea of just creating a municipal CON and then saying, okay, you guys can come in and do the service, and then at some point expand your operating authority. That, again, it seems to me to be an end round around process. If Lancaster wanted to expand into the town of Alden, they should have straight up put in for an expansion of operating authority right from the very beginning. And we could have gone through that process, and that could have been brought before the REMSCO, and they would have had the opportunity to decide that on its merits. So my concern here, again, is that this is a kind of going around processes that have been established. And we should be able to find a different way of doing that. Hopefully through the revision of 0606, we will. But presently, as it stands, I don't believe this is the correct way of doing it.
I believe the devil's in the details, and there was recourse. The municipal CON could have been converted and transferred to Lancaster. And that seemed to be something that was lost in the details of the discussion. There was recourse, and it sounded more yesterday during discussion like a gentleman's agreement between the town and Lancaster that we're going to go ahead and do this municipal CON, but you can get your expansion later. Again, my concern is that's not how it works. We have rules in place. Do I agree with the rules? Do I agree with all of 0606? No. But if we want to change those rules, we need to change those rules. We can't just overrule REMSCO's because we think it's a good idea. We need to recognize that the REMSCO made the right decision, given the information that they had and the information that was provided to us, and we need to support the REMSCO in that decision. If we'd like to change the rules and change the policies, we can do that, but we need to stick with what's on the books.
I guess I don't see, and maybe I'm confused, how this is an end run or trying to change the rules. There's an entity that had a muni CON, and they contracted with another agency to provide service there. That agency then could not prove need in that town because they were already providing the service. Having dealt with municipalities, I can understand how a municipality would, in extremis needing service, get a municipal CON, but then not want to be on the hook to be the provider. The contract that was in our packet between the town and Lancaster stated that they would contract with Lancaster until such time as Lancaster could get their own CON. It's not a TOA. It is a new application from Lancaster to expand the territory, which is supported by the municipality. And the municipality wants them as a provider. That was what I was basing my vote on.
And I fully understand that. Again, it's a matter of, we have heard this number of times in the past. It's not a matter of wants, but a matter of needs. The town may want not to be an ambulance service provider, and that very well may be fine, but that's the way the Municon system is set up. We may not agree with that, but that's the system that is established. Municipal CONs can be granted without any review by the regional council. There's no determination of need. A municipal CON can be just said, hey, we're the town of whatever, and we want to have an ambulance service, and they can do that. And now there's a recourse after the fact where we go through the process of making it a permanent municipal CON, where there still has to be some determination of need with the strong presumption of need based on the fact that the municipalities requested it. So that all makes sense. And again, if the municipal CON was converted into a permanent CON and they wanted to continue having this agreement with the Lancaster Volunteer Ambulance, that's perfectly reasonable. And that's the way it's designed to be. But in order for Lancaster to take that over from them, because for the best of my knowledge anyway, if the municipal CON were to be made permanent, they would still have that. That CON for the town of Alden would still exist. So now you have two operating authorities within the same area. The town of Alden and now the extension by Lancaster Volunteer Ambulance.
Just for discussion, this did come up at Systems. They talked about this extensively. The municipal CON was made permanent. The service applied for their own CON and advised the town that should they not be able to get a CON, they will cease service to the town. The town has no resources to be able to provide EMS on their own. They own no ambulances. They have no ALS support. So in the documents that were given to us, it says that should this body not grant the CON that was denied by the region, they will cease service to the town. There are letters of support from the town to allow them to expand their operating certificate or to get a new CON, whatever you want to call that, which is how the opinion was written.
So, I'm sorry, Mr. Chairman, but the way I read that statement made by the representative of Lancaster Ambulance at the public hearing was that they would continue to provide service if they were not granted the CON. That was on the public record. So if that's changed since then, that's new information. And I would also submit that our knowledge of the fact that the Municon was made permanent is also de novo information because that was not in the records. So again, going back to the statements that were made at the beginning of the Systems Committee, we're not allowed to consider that. Now, again, it shouldn't make a difference because at the time that all of this started, the Municon could have been converted. The Municon was still in effect. So again, they could have continued that process right along. And all I'm saying is, I don't agree that there should be no EMS service for the town of Alden. I don't agree with that. What I don't agree with also is that the process that's being followed does not comport with the rules that we have established through either 0606 or Article 30. If in the wisdom of this body we choose to overrule the REMSCO, we certainly have that authority. But it calls into question how every other REMSCO is going to deal with similar situations because more and more municipalities are getting municipal CONs, whether they be towns, villages, or counties. And this problem is not going to cease here.
It doesn't sound to me as though, without sitting here for another hour and a half, that we're going to resolve the questions that are being raised. And I wonder if we should, as a SEMSCO, ask Systems to do a little bit more review of the records that's there and clarify some of these questions that have been raised, and then bring this back to us.
I would make.
I'm not opposed to it and would ask that if people have questions to reach out so I can answer them specifically and to the group. There's definitely some question with the ALJ's opinion, and my question probably to the director is, can we resubmit that to ALJ to have it reviewed?
Just to make sure I have hear it right, so you're asking, can you ask the ALJ questions related to their recommendation?
There's a lot of question surrounding the ALJ's opinion and whether or not the ALJ completely understood all the specifics of the appeal. And the question is, can we ask the ALJ to review his opinion with some specifics and see if it stays the same.
Would that be considered new information?
Yes, if it would be considered new information. I don't think it would be considered new information if they're questions, not things of that nature.
I think the questions revolve around expansion of territory, CON, which is what this is, versus muni CON conversion, which this is not. And both were referenced, or the muni CON was referenced in the ALJ decision, and this is not a muni CON conversion. So his understanding, or the person's understanding of what he was being asked to look at was not clear in his subsequent judgment. He was thinking one thing and it was another.
I'm not sure. So in reading the AOJ's letter, I'm not sure that's the case. They specifically state, while the applications filed by the applicant were framed as requesting expansion of services, so they clearly understand what they were requesting, they state they essentially sought conversion from operating under the muni CON to operating in those geographic areas under a permanent CON. What they were saying in their letter is that the demonstration of need, as presented by Lancaster, is met because it cannot. They can't say that the need is not there because they're currently operating under a muni CON. What they're saying is that the muni CON and they're operating underneath it is the exact definition of need for this community. So the ALJ said, while the applications filed by the applicant were framed as requesting expansion of services. So what they're saying here is that they understand that this is an expansion of services, and they are using the muni CON conversion process to state that there is a need demonstrated for the permanent CON and the expansion of services.
I believe the proper move still would have been for a transfer of operating authority from the town of Alden to Lancaster Ambulance. They converted their MuniCon to a traditional CON. Once it's a traditional CON, if they wanted not to be in the ambulance business, they should have transferred their operating authority and we wouldn't be here.
I don't believe that is able to be done.
I asked that very question a few months ago for an agency in our region. And even though 0606 suggests that a MuniCon is tainted, there's nothing in Article 30 that says that it can, once it's transferred to a traditional CON, there's nothing that prohibits it from being transferred later on. There is no regulation that says that it can't be.
So you might have solved their problem.
Well, I would tend to agree with that. Just a country boy here.
Don?
I mean, there's a number of, and rightfully so, a number of different issues raised, but I think the topic at hand is, based on the appeal itself, does this body have enough information? And that being said, I'm not conflicted, I'm frustrated that in the meeting, in many meetings, we discuss an essential service, thereby compelling municipalities to acknowledge the need for an EMS system and an EMS agency to service their area. This seems to be that case where we have a municipality that says, we need somebody to run ambulances in this area. We've found somebody to run ambulances in this area. They have been running ambulances in this area. They'd like to continue to do so, and it falls before this body saying, can they continue to do that? And in order to do so, we grant them the CON expansion, which is clear that that's what this is. That's what the appeal is that this is a rightful expansion, uncontested seemingly by anybody, and I don't want to derail home rule or any other right of a municipality to protect their citizens. Now, that being said, I also don't like overturning local REMSCO authority and control, because who better to know their area than them, not me, that I couldn't point to Alden on a map. But it doesn't matter to me geographically, it matters to me on principle. Who's running those calls right now today? And how do we get them to keep doing it tomorrow? Unless there's somebody else that's willing to. But the question before the committee is, the appeal's been filed on an expansion. What do we do with that? And I think the Systems Committee did kick this around, and that's the purpose of subcommittee, is to do all that legwork and then come to us with their expertise saying, this is what we recommend you follow through on.
So Don, this is David. To your point, it sounds like we have an opportunity in front of us to both help the EMS system and grant them the ability to continue doing what they're doing, and at the same time, make it easier moving forward by changing policy or regulation to accommodate such things in the future.
I'm just saying I wish I had more ambulance services in my area that wanted to run calls. And it seems like that's the case someplace else, and they've found a way to do that. So I might want to move to Alden. Once I find it on the map.
I just want the record to show that Don's looking for more ambulance services in Nassau County. Next time he brings that one up.
As we said, it takes everybody.
So, as I understand it, and I understand the fear about losing an ambulance service, but my understanding is that the town of Alden contracts currently with Lancaster Ambulance. That contract is amicable. Their plan was to shuffle things around so that Lancaster Ambulance could do its own billing and reimbursement rather than running it through the town. That's a little bit different than saying, we can't run an ambulance here tomorrow if this doesn't happen today. I just do not like the idea of disregarding the rules and the regulations because it makes us feel good about doing something. If we want to change the rules and the regulations, we do that. But we don't just overturn decisions that were made in good faith by REMSCOs because we want to feel good about what we did.
So if you read the meeting minutes from the REMSCO, it's stated publicly that the committee was not only unanimous in its decision, it was unanimous in making note that LVAC is trying to do a good thing here with regard to the billing and other things. But regardless of good intentions and the things that they did, the law is the law. That's stemming from the statement that they have not demonstrated that there is a need. And Mr. Gill says, I think the definition of need has to be reconstructed to address situations like this. It doesn't really seem to cover the situation that we're dealing with. The administrative law judge stated in their statement that the Muni CON does demonstrate need. That is our purview here. Is there a need? Since the REMSCO said there is no need, the administrative law judge and you're up to our own decisions here to figure out whether or not that coverage by that ambulance service is meeting a need. That is what we're tasked with. Is there a need in this community, and did the REMSCO not see that there was a need and misinterpret it? That's our decision at this point.
The presumption of need is in favor of the holder of the municipal CON.
Which in this case is not Lancaster. It's town of Alden.
That's correct.
What's the motivation for them wanting their own CON? They want to raise the prices, or what do they gain out of it? And if all they're doing is to gain control over billing, that's not, in my 0606, it doesn't say anything about that as being a need.
You know, operating an EMS agency under a MuniCon, while, you know, on the streets, it's identical. Administratively, it can be challenging, you know, from CMS rules, and that's just the billing arm of it. There are other regulatory, you know, hoops that can be done. And I think, you know, from an operational standpoint, going long-term, you know, if the town doesn't want to be in that business and have a little more hands-off approach, that's probably some of the motivation behind wanting the agency, the EMS agency, to have their own, you know, CON and run it.
Though I do agree that maybe Alden does not want to run a business anymore, they got into the business when they needed to. And they don't just get to obfuscate that responsibility by just turning their hands up and saying, somebody else do it now. LVAC is currently providing service there under the MuniCon. That need is satisfied. Wants and desires are things that are extra and above the definition of need that we currently see.
So it would appear that we're talking about a lot of questions and ifs and intents and procedural things that aren't going to be handled at this meeting. And there's a seconded motion on the table. I don't know. I think we're going in circles, and it might be time to come back to that seconded motion and make a decision.
Shall we call the question?
Or just a point of order, can we table the seconded motion?
Are you making a motion to table it?
Sure, I make a motion to table the seconded motion until further review and time to digest and look into this.
Do we have a second to table?
Sure.
I'm no parliamentarian, but I don't know that that's proper because the point of a second is to force the vote. So I believe, I'm going to go out on a limb here and suggest that we have to do something with this second in order to then do something else with it. I know Mike's head hurt.
No, a motion to table takes precedence. You can table anything at any point.
On that, Mike, on that, for the motion to table, can we get another motion to get, you know, exactly what we want? Obviously, we'll have the time to review the documents, but I think the question is the opinion that was attached to the packet, to have that. Is that possible to have it, you know, saying, re-looked at?
I think at this point, there's a motion to table on the floor. While that is while that is in progress, we can't make another motion.
The motion to table needs a second.
It has a second. Yeah.
I apologize. I seconded the motion to table.
All right, so let's call the question on the motion to table since we're not supposed to discuss it. So all in favor of tabling this motion that you see on the screen, raise your hands.
By the way, correction, you are allowed to discuss a motion to table. You can talk about it for the next hour, you can talk about it. If you don't want to talk about something,
thank you, Dr.
then
Langston.
you make a motion to close the discussion. That's a different motion. But go ahead, take the vote.
All right, let me go back to where I was. If you're in favor of tabling, raise your hand. Can we count the hands? 1, 2, 3, 4, 5, 6, 7, 8, 9, 11, 12, 13, 14, 14, 15, okay. 14, 15, either way, it's tabled. Yeah, all right. So 15 hands are raised, so the motion carries.
As per Dr. Langston, can I go to discussion?
Any opposed? Raise their hands. All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. All right, so 10 hands are opposed. All right, 10 hands are opposed. So, and we need a simple majority in order to table it, right?
I don't hear you.
10 hands were up, opposing it, 15 in favor.
Well, what's the majority? How many members are there on the committee? It's a simple majority. How many people are there in the committee? I'm sorry, what? So you need a half plus one.
So simple majority is 17? All right, so it fails. The motion to table fails.
Now, if somebody wants to stop talking and go home, they can make a motion to stop debate, requires 2/3 of a vote.
In other words, a motion to call the question.
That's exactly what I'm saying.
All right.
I'd move to call the question.
All right, so there's a motion to call the question by Donnie Duval. Who
I need
seconded?
2/3 vote.
Jeff Raybridge. Do we need to vote on the motion to call the question?
2/3 vote.
Oh, my goodness. All right. So we need
You want
2/3
someone to shut
votes
up, you gotta
to
be
call
very
the question.
powerful at it.
So all in favor of calling the question, raise your hand.
The vote.
All right, so 22. All opposed to calling the question, raise your hand. One. All right, so now we will call the question, which is, I cannot read anything on the screen, so the question is,
I could read it for you.
please.
Motion to reverse the decision of the Wyoming Erie SEMSCO, SCOs, and to grant the con for the town of Alden passes 8 yes, 2 no. So they made a motion to table the seconded motion for more time to review, and that carried.
No, that's our
Oh, okay, I didn't see that put in there. The original motion
The
then,
original motion is all that you're talking
from
about.
SEMAC.
That was from Systems.
Okay.
This is a seconded motion coming from Systems. All right, so this is a roll call vote.
Yep.
No,
Can we clarify what yes means and what no means? Yes means that we are overturning the SEMSCO decision and granting the CON. No means we are upholding the SEMSCO decision and denying the CON.
thank you, Beth. So this is a roll call vote. Roll call.
I have an inquiry which is not, I consider a discussion, but we are granting a CON to a town or we're granting a CON to Lancaster? Well, it says the town.
I can't read what it says there.
I thought we fixed
believe
that.
it says town, alluding to the geographical boundaries known as the town, not the town as an entity. The CON relates to primary operating territory.
That's the right one. I think.
Yes. We're doing the town. The
Yeah,
village
actually,
is
no,
coming.
that was the vote for the village. That was the village vote, but we fixed the wording on the village. We never fixed it on the town.
You don't have the right wording on the screen.
I believe this was one for the village, but the wording is correct. Yes. You could just leave it, grant the CON for the town of Alden to Lancaster.
No.
No, okay, never mind. To Lancaster Volunteer Ambulance Corps. And you need to take out the own of Alden.
All right, can
Mark,
you
is
read
that-
it to us
Is
now?
that the correct verbiage on the screen?
It says motion to reverse the decision of the Wyoming, Erie, Remsco, and to grant the CON to Lancaster back.
And to get rid of the second, on the second line.
Down here?
Yeah, to pass this system.
Oh, that's just our notes. Those are our internal notes.
Because there was separate CONs for the town and the village is why the town was in there. It was grant the CON for Lancaster to serve, to expand their territory to include the town of Alden. Because then there's another one for the village of Alden.
Right, we haven't got to the village yet. So Beth, again? Beth? A yes vote means?
Yes means to overturn the REMSCO's decision and grant the CON. No means to uphold the REMSCO's decision and deny the CON.
Thank you. Can we call the roll?
Steve Katie,
Steve Katie, after discussion, I vote no.
Scott Clark,
Scott Clark, no.
Is that no? No. Mark Devers,
No.
Don Duval,
Duval, no.
Michelle Fornes,
Mickey Fornes, yes.
Carl Gandolfo,
Carl Gandolfo, no.
Gregory Gill,
Gill, yes.
Jason Haig,
There we go, that works better. Jason Haig, no.
Teresa Hamilton,
Teresa Hamilton, no.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Isaacs, no.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, no.
Jared Cutson,
Jared Cutson, yes.
Al Lewis, he's not here. William Masterton,
William Maston, no.
Mike McAvoy,
Mike McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, no.
Mark Philippi,
Mark Philippi, no.
Dr. Raybrich,
Raybrich, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
Davis Simmons, no.
Carla Simpson,
Carlos Simpson, yes.
Christopher Smith,
Chris Smith, yes.
Chad Smith,
Chad Smith, no.
David Violante,
Violante, yes.
Dr. Langstrom, this is two-thirds or majority?
So 15 voted No. To deny. 11 voted to grant.
So there were 11 yes votes and 15 no votes.
So we need 17.
Majority is 17.
Just a point, point of order, I have the bylaws, current bylaws up. I hope these are the current bylaws. Section 7, voting. The affirmative vote of a majority of standing committee members present shall be required to carry any motion on the matter before such committee.
So the motion fails. It was denied. All right.
Point of order on top of the bylaws, doesn't general construction law state that it has to have the seated members, not the present members? Just throwing that out there.
Wajia, this question's for you. That's the official answer. I'm happy to step out and call legal if you'd like me to.
Perhaps while you do that, we can move on to the village.
Be happy to step out.
Steve, I looked at the bylaws that I currently have, and it does match what you're saying, where it says, all statutory action by the state council shall require a roll call vote by all members present.
That makes sense because you couldn't hold the meeting unless you had a quorum of your total membership, so.
We've had this debate many times in the last 10 years, and we seem to always forget what happened the last time we have it when we bring it back up again. There is a conflict between general construction law, Article 30, and our bylaws, and Division of Legal Affairs has invested great amounts of time with Dr. Langsam usually helping as our unofficial parliamentarian at the time, now official parliamentarian, that we go with the majority of members present. I'm not saying that that doesn't have to be revisited, but I think none of us want to revisit it this afternoon.
Okay.
If that's what we've done in the past, then we should continue.
That's
that
correct. I have argued against the lawyer, but the lawyer who, at this point, rules, agrees with what you said, that we do it a simple majority. I think we're in violation of the general construction law of the state of New York, but that's going to be left for the courts. I've said that many times. It's up to the court, not for us to decide this. I'm not even a lawyer, and lawyers can be overturned. So if someone wants to challenge that, okay, which I think they might win, but that goes to the court. As far as we're concerned, our legal said that a simple majority rules, because that's what Article 30 says, even though it contradicts the general construction law of New York State, which does say that it takes precedence over everything else. But again, I'm not a judge and I'm not a lawyer. So
All
you're
right.
correct.
Well, Ryan's checking on that, but let's go with what we
Ryan
have done.
checked on this with me now 10 times
Right.
outside the room. This is
And while we wait for that, why don't we move on to the village?
So I have a quick question, Mr. Chair. If that's the case, and it's a simple majority of those seated, then did the motion to table in fact pass?
It was a simple majority.
No, it's a different standard, and,
No, it actually does a simple majority.
Okay.
yeah.
No. Motion to table is not two-thirds. A motion to table is a majority, like everything else. A motion to stop discussion is two-thirds. To call the question is two-thirds. No one listens.
All right, let me call for a 5-minute
Yeah,
recess.
thank you. I was just gonna-
Huh?
Sure, people stuck at the back. I'm not sure if we're gonna have a quorum now.
We can ask the stall
You can't win when it comes to lawyers. Hope no one's a lawyer on here, but you can't win. And my daughter's a lawyer.
We won't hold that against her.
Huh?
We won't hold that against her.
She's a district attorney, so she's on the good side.
Are you happy now that you actually became the official public?
Okay, let's reconvene the meeting.
Good luck.
Back?
Okay. Where's Steve Jazura?
I'll see you there. Take care. Have a safe trip.
So the answer to these questions is, well, let me back up. The motion to table actually passed. So this was tabled. And in order to start the meeting, we need a majority of vetted members in order to start the meeting. And in order to pass any motion that we do here, we need a simple majority of those vetted members at the table. So that means to start the meeting, we needed 17 people. We had that. Does it appear as though we've gone under that at this point? No. Okay. We're not that lucky.
Mr.
So-
Chair, to cover ourselves with the next CON vote and majority rules and all that, may it be recommended to call the roll one more time to assure we have 17 people?
Well, it appears as though we're significantly over that number at this point. so.
Okay. Just wanted to ask for procedural
Anybody's
stuff.
allowed to call, anyone's allowed to call for a quorum, so which means if someone's asking whether there's a quorum, then you need to take a roll call to make sure everyone does a quorum.
Okay, since Jason wants to call a roll call, let's do a roll call.
I don't care, but that's. Maybe we won't have a quorum, we'll go home.
Allison Berg. Steve Katie,
Steve Katie, present again.
Scott Clark,
Present. Ms. Allen, could you pull the microphone a little closer, please? It's really hard. Thank you.
yes. Dr. Krupe, Mark Devers,
Still here.
Don Duval,
I'm still here.
Michelle Fornes. Here. Carl Gandolfo,
Still present.
Gregory Gill,
Here.
Jason Haig,
Jason Haig here.
Teresa Hamilton,
I'm still a present.
Don Hudson,
Ready to proceed.
Dr. Isaacs,
Isaac's present.
Al Kim,
Here.
Steve Kroll,
Still present.
Andrew Knoll,
Still here.
Jared Cutson,
Here.
Alan Lewis, William Masterton, Mike McAvoy,
Regrettably here.
Elizabeth McGowan,
Present.
Mark Philippi,
Present.
Marianne Portoro, Dr. Raybrich, Dr. Redlener,
I'm present.
David Simmons,
Present.
Carla Simpson,
Carla Simpson, present.
Christopher Smith,
Present.
Chad Smith,
Here.
David Violante.
Violante here.
We have quorum.
We do have a quorum. So do we want to do the village next?
Can I make a point of order? Just to remind you all that since it was tabled, not a matter of being postponed, it was tabled, which means you need a vote at some later date to take it off the table. It doesn't automatically appear at the next meeting. That would have been a motion to postpone.
Yes.
There's a motion to table, it's on the table
Forever,
and ever
until
and
we
ever,
take it
unless
off.
someone makes a motion to take it off.
Can I move to take that Town of Alden Lancaster ambulance motion back on the table? Put it back on the table? Take it off the table.
You can make a
I'm
motion
gonna
to take it off.
the table.
A point of order, I believe that you have to wait one meeting in order for it to come, in order to resubmit it back to the table.
I don't think
But
so.
I could be wrong.
I don't believe that's correct. I think it can come off
Okay.
or go on at any time. So
To
if
cancel
you,
a previous action, which is what he's asking to do, requires a two-thirds vote or a majority with notice. So therefore, you're both right. Either you wait till next meeting and have a simple majority, or you have a two-thirds vote now to take it off the table. You
Let's
decide what
get
you want
this
to do.
done. That's my motion.
What is the other action you could do to,
do we have a second to the motion by Don Duval to take this off the table?
I'll second it so we can do something.
So seconded by Mark Devers. I'm just reading Robert's rules here quickly.
It's too complicated.
Two-thirds vote. No, you don't.
What are we waiting for?
Okay. According to the Roberts rules, you do not need a two-thirds vote to take a motion off the table.
According to
You
Robert's
need-
rules, which I'm saying, I'm looking right here. Okay. To cancel a previous motion requires a two-thirds or majority with notice.
Majority with notice?
Yes, that means what someone said before. If you wait till next meeting, you don't need 2/3. If you want to do it now, you need 2/3.
All right, this says to kill a motion
That's a different
that
motion.
has been tabled.
We're not looking to kill a motion. That's something different. To kill the main motion is a simple majority vote, but we're not doing that. We have no killing of a motion here.
No, to kill a motion that has been tabled. So we're taking a motion that has been tabled off the table. You're saying that requires a 2/3 vote?
Now it requires a 2/3 vote. If you wait till next time, it requires a simple majority.
All right, let's see how many votes we get. All in favor of taking the motion off the table, raise your hand. That would be the maker and the seconder. All opposed to taking it off the table, raise your hand. All right, so 2 votes in favor of taking it off the table, 20 votes opposed to taking it off the table. It will not come off the table tonight.
Remember that next meeting.
So do we want to do the village?
I make a motion to postpone or table.
What are you postponing? Or the other one?
Okay, I make a motion to table the village.
I will
The,
second
the
that.
extension, CON extension for the village of Alden.
I'll second that.
All right, we have a motion and a second to table the CON for the village. Discussion?
I'd ask, what's the purpose of tabling things? I mean, they've come to us, they've been waiting 4 or 5 years for a decision, and we just keep pushing this away. What's the purpose of continually tabling?
I'll discuss that. I am tabling because I have not had the time in 96 hours to read the 900-plus pages, 40-some documents, to make an educated, reasonable, responsible decision. I know during some discussion we've had here at this table, there was discussion about they're going to pull out. I remember reading that they said they weren't going to pull out. So now I have to go back in right now and try to find where I thought I read that they, LVAC said they will not pull out. It doesn't matter what happens here. But somebody said they were going to pull out. So how can I make a good quality education decision if I don't have that good quality information?
And
That's
I'm a
why
little
wanna table
confused
it.
because I would prefer to bring this back up and finish it tonight, but apparently I was in the minority.
By the way, a motion to table is non-debatable. So if someone makes a motion to table, just vote on it. Don't talk.
All right, we'll call the question on the motion to table the village. All in favor of tabling the motion on the screen for the village, raise your hands. Twenty-two in favor. All opposed to tabling the motion for the village? one opposed. Any abstentions? One abstention. Motion carries to table. Now you have more motions, correct?
Regrettably, just one. Miss Allen, it's the one on 7 to 10 days to have information to us prior to the meetings.
Mark, can you repeat what that motion is so we can get it typed up?
Yes, ma'am. The department shall provide all associated paperwork for CONs 7 to 10 calendar days prior to a meeting.
To provide all documentation
Yes,
7 days prior to,
7
Meeting.
calendar days prior
7
to
calendar days.
a meeting.
Was it at least 7 days?
Yes, at least 7 days, I'm sorry.
Prior to meeting at least. Okay, thank you.
Miss Allen, according to Trish behind me, it's for all actions coming up to vote, not just CON. Which I believe that reads.
So can you read that one more time?
Motion for the Department of Health to provide all documentation at least 7 calendar days prior to a meeting, or to the meeting.
Any discussion on this motion?
Mr. Chair?
Give it a second. Was there a second already? Yeah, it's a second. It's a seconded motion. Oh, it's a seconded motion.
It is a seconded motion
All right.
coming forward
Trying to
from
move-
the Systems
Trying to move
Committee.
the process along.
Mr.
And I'll
Chair?
rescind that second.
Coming from one committee, I think this is a great idea. I think it allows the opportunity for other committees to sort of be rolled into it if that's the case. And they may have varying timelines in addition to what's happening at the Bureau. So I'd like to propose that perchance this actually go to the executive committee to work out a solution with the Bureau and the other committees to come up with an efficient and workable timeline that affects all committees, because this will affect all the other committees, but it came from one.
Are you proposing we table this?
Can
You
I
wanna do that? There's
make a
already a motion on the
recommendation
floor.
on some of the
Making a
documents
second motion on top of the
that
first
are
motion?
shared have a level of itemizing? I know some of these documents that are uploaded on Boardable particularly for CON actions, are a single PDF with hundreds of pages, and it's difficult to discern, what is the appellant's document, the original, the minutes from, let's say, the REMSCO where it came from, and then the ALJ's opinion. I myself, from being at REMSCO in one of the actions here, read everything, I lived it, so I didn't even find the ALJ's opinion, thinking I read it all, and I saw the receipts for the certified mail, and I figured that was it, and lo and behold, it was the last page, and it was there all along. And so, of course, it's my fault. I didn't thoroughly scour the document, but it would have helped if it was a little bit separated.
Dr. Langstrom, my recommendation isn't a proposal on top of the one that's already out there. We'd have to finish that one first. But that's my recommendation, that we allow the executive committee, as part of discussion, we allow the executive committee to manage this with the Bureau and come up with a good timeline for all of the committees that are affected by this.
So, David, would that be referring the motion to the appropriate committee with instructions to report back?
Yes.
Yes.
I think it's important, I think it's important to make sure for the CON process that the next time we're not stuck in the same cycle. And I think that what I'd like to do is make a motion to amend this to include only the CON documents. And I'd like to make a motion to amend.
I believe the Systems Committee added to be fair, the opportunity for other committees or other areas that might feel the need to have similar timelines, to review for documents, for actionable documents.
I agree with that, and I'd be happy to support a separate motion to do that if we feel that it's necessary. But I think for the ease of the process, so that we don't have to go to the executive committee, I think it would just be more straightforward to make that amendment.
I would worry that we would start getting different timelines from different committees for the DOH to then meet. One committee could be 7 days, one could be 10, one could say 15. I think it would be important to have a standard.
And I agree with that, and I think that's why it might be proper sending it to the executive committee, as the executive committee is made up of the chair of each standing committee to prevent that very instance.
I'd agree with that. The people that approve all of these documents before they go out to us as members to vote, they have within the Department of Health somewhere around 90 different committees that they're responsible for. So I think having multiple different scattered timelines would not be in our best interest. So I think, I'll support Mr. Violante's proposal that this goes to an appropriate committee for action.
Quick point of order, Mr. Chair. Mr. Violante made a motion, and do we have a second on it?
Well, I don't know if you can make a motion while there's a motion on the floor. This one's on the floor. And I don't believe you can amend a seconded motion.
But I believe Mr. Violante wanted to send it to the executive committee through a motion, which if he did make that motion, I would second it.
I'm very unclear. What was the last motion? The last motion I heard was to refer to committee.
Mm-hmm.
That's what's on the table right now. That's
Yes.
it.
Mm-hmm.
No, but that was a motion, can take that motion to send that motion to committee is appropriate. But it's not tabling, it's sending it to a committee.
Okay.
Yeah.
So,
And that does not require a 2/3 vote. That's a regular majority vote, and it's debatable.
All right, well, then, let's start the debate.
Okay.
I have a question. What would that mean? I mean, it just means it goes to the committee and then the committee decides. I guess all I'm trying to prevent, and I don't mind how it goes, but just to prevent this next time, and right? So by the next time that we meet, that the documents are there and available and everything is ready for all of the committees to review. That's my only point.
Nothing you
of this
can do
whole-
to force that. Congress does it all the time, sends things to committee and it never comes to the floor. That's why you have an executive committee.
I mean, that's why I was thinking differently about it, so.
The committee chairs had a pretty robust discussion this morning about timelines. The timelines of the documents we submit, the timelines of when we see things. This sort of caused that discussion to occur. And Ryan and Steve were both present, and they talked to us a little bit, actually quite a bit, about the process they go through internally at the department. As Jason mentioned, there are 60 different councils that they're working with. I think that it would be good to give the executive committee and the chair especially a chance to work with the staff on coming up with solutions. What I said this morning is, look, we're all trying to figure out how to work together and hold each other respectfully accountable for how to get the job done. Nobody wants things to occur at the last minute, but sometimes they have. And so, I mean, I'm not against the proposal that we have 7 days of receive materials, 7 business days ahead, but I do believe that it would be good to let the executive committee, the chair, and the director, assistant director, work on this and come back here in December and say, okay, we figured out a way that we think we can improve the processes and get everyone the things that we need to do in time. So I would support David's motion because I think it's a good faith effort by the leadership of this body to try and get us to a better place.
I would support that as well. And I think that passing this the way that it appears here may have some unintended consequences for our meetings in the future, because we're telling an organization that has a very difficult time moving quickly to move at a certain speed, which could then result in them saying, well, we can't meet your deadline here, so cancel the meeting. So I think let's give executive the opportunity to work with the Bureau and figure out a way that we can make this work as painlessly as possible for all of us, because I think we've heard the issues here multiple times the last 2 days about getting information in a timely fashion. And we're creative people. We could figure out a way to make this work. So if there's other discussion, we can vote on David's motion to turn this over to the executive committee. Any other discussion? All in favor of turning this motion over to the executive committee, raise your hand. I don't see any hands not raised. Twenty-four in favor. Any opposed? Any abstentions? All right, the motion carries. No opposed, no abstentions. At the risk of asking, do you have anything else?
Fortunately, I have nothing else, and I apologize.
All right. Al Lewis is not here, and I think he had to leave for an emergency. Steve, do you want to give his legislative
Yes.
report?
Good afternoon, everybody. Al had to leave early and asked me to give the legislative report. There's a working document that was posted for members of SEMSCO to see, And that has to do with the charge that the legislative committee's been working on over the summer. Several meetings were held. And the purpose was to formulate policy recommendations for the future after evaluating the things that have happened over the past year in the things that have happened in legislation. And certainly there's been legislation passed that works for us. So the committee began looking at possible areas for us to go forward. There is a seconded motion from the committee that Teresa has that we can bring up in a minute. I'll just tell you that the committee identified 3 areas we feel that further policy development would be good, that we would recommend to the Department of Health that they ask that these things be included in the executive budget. Number 1 is over the last 2 years, an attempt was made to redefine the term EMS. And different language in Part F 2 years ago, different language in Part S this year. Neither year it was adopted. We have submitted, and you'll see there, we've agreed on consensus language that would, again, suggest that we redefine the definition of EMS to more accurately define the role of clinicians to what we do currently perform and what we believe we should be performing in the future. So that's the first recommendation. I'm giving these recommendations to the committee in block, but as we discussed at the committee meeting yesterday, there are 3 standalone proposals. So we may send 3 proposals to the Department of Health, and they may advance all 3. They may advance 1 of 3, 2 of 3. They may want to tinker with them. So that was now the first proposal. The second proposal is about the concept of treatment in place and transporting people to alternate destinations. Since the decision to terminate the ET3 program, the national EMS associations, such as the National Association of EMTs, have proposed legislation that would authorize the reimbursement for treatment in place and alternate destinations by the Medicare program. It doesn't set the rules for it, it just authorizes the reimbursement. We have converted that over into a similar New York State recommendation that New York State authorize reimbursement for treatment in place and transport to alternate destinations. Again, it's not a program, it's not an ET3, it simply says Medicaid should pay for this. So that is the second recommendation. The third recommendation has been more organically grown out of the work of this committee, which is several attempts have been made, both through state budget and through state legislation, to define EMS as essential. And we always come back to the question, what is essential mean? So what we have done is come up with, you'll see it when you, look at it, there are 4 bullets that are our recommendations for what New York State EMS becoming essential would mean. To just quickly paraphrase, ensuring New York State should require that in every community there be a designated government entity responsible for ensuring funding for EMS and readiness, and that EMS services provided meet New York State performance standards. It would lay out what the types of agencies are, that these government entities, who they are, so counties, cities, towns, and villages, that they could act individually or jointly. In the absence of a local jurisdiction taking responsibility, the defaults to the state. And lastly, and quite importantly for us, that the government entities must work with the holders of the EMS operating authority within the jurisdictions to incorporate their capabilities into the EMS response system. In other words, this is not saying to local government, you go and you build it. It's saying to local government, you're responsible for it, and these are the partners that you have that provide that service, so you need to work with them to define how it's going to be provided in the future. So this is the third bullet. These are the 3 things that have been done by the Ledge Committee. This is a working draft that we have provided to you. Several members of the committee have made some comments about it, and there's a little bit of fine-tuning to be done. What the motion that we have is, and if you can put the motion up, all right, And, all right, I can't, it's too small for me to read. My eyes have, over 20 years here, my eyes have gotten a little shot. It's a motion for the Legislative Committee to recommend that the SEMSCO authorize the Legislative Subcommittee I'm going to have to walk. Can someone that's closer read it? Because I really can't do it. Peter, do you have a microphone, or?
I got it.
Okay.
Motion for Legislative Subcommittee to recommend that the SEMSCO authorize the Legislative Subcommittee to fine-tune the draft policy recommendations for the 2024-2025 New York State Executive Budget discussed at the September 12th and 13th Committee and Council meetings, and then immediately submit such to the Bureau of EMS for submission to the Commissioner.
Thank you. I will be getting new glasses soon. But the essence of the motion, translating it into plain speak, is this document is 99% done, but it did not get into the executive clearance process in time for it to be finalized at this meeting. If we wait to vote on it in December, we miss the train of the work that's going on in preparing the executive budget. So we're essentially asking SEMSCO to give the legislative subcommittee, so Al's committee, permission to finish the fine-tuning of this and submit this to the Department of Health with the SEMSCO's blessing between now and the next SEMSCO meeting. So in the next couple of weeks, basically. So, that's our motion. We're open to discussion, of course, on the motion, but also on the substance of the things we're proposing that were worked on by the Legislative Committee.
Any discussion on the motion? If not, all in favor of the motion, raise your hand. All opposed to the motion, raise your hand. Any abstentions? All right, one abstention, 23 votes in favor, no votes opposed, so the motion carries. Any other report from legislative?
That is the full report. Thank you.
Moving right along, safety. Andrew?
Thank you, Mr. Chair. I'll be quick. We continue to work on policy 0013, revising that to a regulation. We hope to have that wrapped up by our December meeting, if not early February of next year. Continue to work on management of escalation tactics. Brian and Mark have put a lot of time and effort in that, and we'll begin to work with EMSC on the pediatric de-escalation process there as well. As Director Greenberg spoke about the Part 800 equipment standards, we met about that in early August. Hope to have them come out for public comment soon. And as he reminded everybody, make sure that you comment, whether good, bad, or indifferent, that your voice is heard. And that is the end of my report.
Any questions for Andrew Knoll, safety? If not, we'll move along to David Violante, quality metrics.
Thank you, Mr. Chair. Thank you, everybody, for still hanging in there and being around. And Mark, there's absolutely no reason to apologize for anything. We meet on the third Wednesday of the month at 1 p.m. It's a standing meeting, so please join us if you're interested and would like to help out and do some work with us. We have a tag form with the folks from the Quality Metrics Committee and the Data Informatics team working together to make recommendations to the Bureau to update policy statements 1202 and 1203. That's ongoing. We've discussed the data PCR elements here today. Thank you, Director Greenberg, for all your work with Schematron change to 3.5, the DI team, all the discussion here from the Quality Metrics group and those present to make that change and continue to move forward with that as we work through the data flow issues that occur among the providers, agencies, vendors, program agencies, et cetera. And so one of the last pieces of that is that while there still may be issues in trying to get some of the data across, and typically that'll affect program agencies and the state, agencies themselves still have the ability to do their own QI, and they should, And so we implore them to continue to do that at that local level. One of the things that we looked at in quality metrics for others was quality metrics for ourselves. And so what are we doing to ensure that we're evaluating how we can improve and go through the cycle and measure our success moving out and moving forward? So we're continuing to do that as well on our own. And finally, as we look towards the quality improvement pilot training program, we were initially asking for a quality improvement webpage on the state site, and what that would entail in terms of putting up our quality improvement paper and such, the manual and the quick start guide. And lo and behold, there is one there under the operations section of the website. So look to that for changes that are coming down the line from our team to go up there, which will include, again, our manual and quick start guide, other resources, etc. We're continuing work on funding our pilot training program through grants and current state resources. We'll update folks as that continues to move forward, but that'll allow us to come out to agencies, out to regions, out to program agencies, and help them develop their own QI systems. And finally, at the Vital Signs Conference, we have a pre-con on quality insurance, the NAMSI program, and that's the first and second days of pre-con for the conference, I believe. So take a look at that in the Vital Signs Conference brochure. At that, we will have the QI manual available in, to some extent, short supply of a printed form and via QR code to take you right there. So unless there's any questions for the Quality Metrics Committee, thank you, Mr. Chair.
Any questions for quality metrics? All right. EMS innovations and research. Jason.
Thank you, Mr. Chair. I'll be brief. Had a discussion on the end of the ET3 project, some of the services that were in the attendance at the meeting, talked about reasons for the end of ET3, the sunsetting of it, and how they're dealing with it. We do have a seconded motion to this committee. Ms. Allen, I believe I did send that to you. You should have it. That SEMSCO supports Medicaid paying for treat in place and alternative destinations. And that falls right in line with what legislative is doing for their proposal to the governor's budget. So I don't know if we can get that up on the screen quickly. Yep, there it is. That comes forward as a seconded motion.
Any discussion on the seconded motion for SEMSCO to support treatment in place and transport to alternate destinations and Medicaid to pay for those? If not, I think we need no, actually, we don't need a roll call vote for this. All in favor, raise your hand. All opposed, same sign. Any abstentions? All right, 24 in favor, no opposed, no abstentions. Motion carries.
Excellent, thank you. Also, another seconded motion that SEMAC and SEMSCO develop a guidance framework on treat-in-place protocols and alternative destinations. So nothing with any work that needs to be done right now, but we wanted it on the record that we would like the assistance of both bodies and probably setting up a work group between them all to start to get a framework in place for the development of these prior to any protocol or regulation proposals. The motion was for SEMAC, SEMSCO state guidance on treat-in-place protocols and alternative destinations. And I'd actually like to change the wording in that if we could, at the bequest of the committee that I was just reminded about, to policy framework versus protocols.
What were the changes, Jason?
So change the wording from protocol to policy framework. Thank you.
Speaking with Dr. Doynow, I would move to refer this to med standards and let it follow that pathway.
I'll second that, Violante.
So there's a motion and a second on the floor to refer this motion to med standards, so it follows the pathway of protocol development.
If I remember correctly, Med Standards did something on this, because I remember working with Dr. Marshall on it. So I think that a lot of this may already be done. So I'll try and find it.
Well, if we refer it to them, they'll be
Then
like,
they'll be
pull
able
a
to dig
rabbit
it
out
up,
of their
yeah.
hat.
Right.
So any discussion besides that? Let's take a vote on referring this. All in favor of referring this to med standards? Any opposed? Any abstentions? All right, 24 in favor, no opposed, no abstentions. The motion carries to refer this to med standards. You may continue.
Excellent, thank you. I've got one last motion from the committee. Teresa, this was a motion for SEMAC and SEMSCO to approach the Public Health Council to assist in collaboratively developing New York State standards to interfacility critical care and air medical transportation. So this would not be a lot of work that's done just within SEMAC and SEMSCO. This would be the committees and councils working collaboratively to not only see what EMS stakeholders have in place, but also what hospitals would want as well.
Mark, could you read that for us?
The Innovations and Research Committee recommends to CMAC to approach the Public Health and, I'll say it all, Health and Healthcare Policy Council, FIPIC, to assist in collaboratively developing New York State standards to interfacility critical care and air medical transportation.
Mr. Chair, if I may.
Go ahead.
If I remember during the meeting, we changed the word standards to guidelines.
That is correct, Mr. Devers. Thank you.
Yeah. So in consulting with Dr. Doynow, I would make a motion that this be referred to med standards also, and let them carry it to FIPIC, which is not an easy process. FIPIC does not do protocols, but med standards does.
I'll second that commit.
Mark Philippi seconded it. Any discussion on that?
Yeah, I do have some discussion. I specifically recommended we incorporate, and the motion's fine, and I'll vote for it, but I specifically mentioned FIPIC because this is not something that we can, this is something that involves both hospitals and EMS agencies developing a process for which patients are handed off by hospitals to EMS and then received back by hospitals. So I thought approaching the FIPIC, the SEMAC approaching the FIPIC to work collaboratively wasn't because I want to write a protocol. It's because I believe that, and Chris is the representative of the hospital field that's here, if we go out and do something on our own that is about what we want from them relative to interfacility transportation for critical care patients, we're only having one of the two players at the table. So I thought it would be good that we reach out to them, and the FIPIC is a way to reach out to the hospital policymakers. So it's fine that we refer this to CMAC to do it, but I think it's a mistake if we try and do it ourselves. And as Dr. Morley said, you know, the FIPIC's enthusiastic about getting involved with us. So let's find a way to incorporate them into whatever the process the CMAC has is, so that we're not doing this in isolation.
I don't disagree. I just want to see this grow legs. Any other discussion? If not, all in favor of sending this motion to Med Standards, raise your hand. Any opposed? Same sign. Any abstentions? All right, 24 in favor, no opposed, no abstentions. So we'll send this motion to Med Standards.
Excellent, thank you. I have no other seconded motions. That was all three. We talked about the Mount Sinai Mobile Integrated Health Community Paramedicine Survey. With the assistance of the Bureau, we're going to be getting that out and looking at results from that with the NAEMT study on community paramedicine and mobile integrated health as well. We looked at some drafts for some infographics. We're going to be adding some more and hopefully have those to bring before a couple more committees at the December meetings. Talked about some different research, and Doug Sandbrook brought up the discussion on some of this interfacility stuff that ultimately led to the motion that you just voted on. And that is the end of my report, barring any questions, comments, or concerns.
Any questions for innovations and research? If not, we'll move on to EMS. Oh, no, I've almost skipped over DEI again. Jared, would you like to give a report on diversity?
Sure.
Inclusion?
So the, well, first and foremost, I should start with the amount of help that we received from Jacob, who, DeMay, who's going to be leaving the Bureau, has been fantastic. So he should be commended for all of the work that he put into developing the survey. So thank you, Jacob. The survey was put out, I want to say about 5 weeks ago. We have about 424 responses to date. We obviously like more responses, so we will keep the survey open until October 31st, which is after vital signs, and we are hopeful that we'll be able to have some QR codes and some signage around vital signs to get people to participate. We've had a lot of responses from the Hudson Valley and Westchester, Monroe, Livingston, and North Country. Not as many responses as we would expect from the New York City or Nassau, Suffolk areas. So we're still hopeful that we'll have a lot more responses come through. And so, you know, it's a long survey, especially if you answer in the affirmative to any of the questions. We're really trying to dig into some of the diversity, equity, and inclusion issues, as well as microaggressions. And so we have, you know, a variety of different questions that have been asked about their current organization and any issues that they have had and why they did or did not report and what they think the actions that were directed towards them were caused by. And so we will compile all of this before the next SEMSCO meeting after the October 31st closing date and have a report for the committee then.
Any questions for DEI? Next is EMS for children, and I think we've Ryan gave some report on that. Dr. Cooper gave some report on that. I went to the EMS for Children meeting, and I can't think of anything that was brought up there that we haven't already heard about. So I'll skip over to the Rural Health Task Force. Is there someone here who wants to give a report on what's going on with the Royal Health Task Force? So Ann Smith is the chair of the Royal Health Task Force.
Hello, everyone. I am Ann Smith, the queen of the Royal Task Force. Oh, no, excuse me, chair of the Rural Ambulance Task Force. And we've made a lot of great strides and coming together and putting together some possible recommendations. We hope to see them more tomorrow at our meeting. The group is broken up, covering 4 different areas of EMS, and the chairs of each group are reaching out to different folks within different organizations for feedback. As Ryan, I believe, mentioned earlier, we do have a survey out there, so we hope that everybody takes the time to answer that. And we will hopefully be bringing forth our recommendations for review prior to anything being submitted or completed or finalized. So I'm looking forward to the meeting tomorrow and hope to have more by December. Actually, we hope to have it finalized by December. Thank you.
Any questions for Royal? This is going to be great in the minutes. Task Force. All right. That brings us to old business. And I do have an item that was referred back to us from the Division of Legal Affairs. At a previous meeting, a motion had come from SEMAC and then also been approved by SEMSCO to allow REMAX to credential providers. I was advised by the Division of Legal Affairs that that motion has no standing, which means we couldn't make it to begin with. So we discussed this at Executive Committee, and in reality, the statutory authority for credentialing belongs to agencies, and there does not currently exist any guidance for an agency on how to do credentialing. Were such guidance in place from this body, SEMAC would work with us to produce that. We would then approve that. That guidance then could exist statewide as the floor for an agency with which a region could make tweaks to it, as we have over the years done with anything else that comes out of here, and with the approval of SEMSCO, do that in whatever fashion they wanted to do that. So our thought process with this, given that we're kind of out of order, is to create such a document and put together a work group of people from SEMAC and people from systems, since this is really a systems issue as well as a medical issue, and come up with some sort of a template guidance document that we could then issue that would say, here is how you credential providers at the agency level. So I will open that up to discussion, and I already have some folks in mind that I've sort of suggested maybe good folks to work on that, and I'll be happy to accept people who want to jump to volunteer for that project. But there are some examples of this being done really well around the state, both by agencies and with regions who agencies have asked to take over that task for them. So I think we have some of that guidance already out there. We just need to put it into format from this body.
So I'll just go one step further on that one. From discussions with legal and trying to portray what we're getting to and what regions are looking for and some of the things. So credentialing does lie with agencies, that is where it sits today. One of the things that can be done, though, and this is part, I think, of what that working group that Chairman McAvoy is looking to establish, is to work on regulations that fall under the statutes to allow a region to determine what that credentialing process looks like at an agency that they would have to follow. So the SEMSCO would need to determine what the minimum standards are for a credentialing process within a region. The region then would have to meet the minimum standards for credentialing, of setting that standards. They may choose to add some different things, but credentialing would ultimately lie at the agency level to carry out what it is that the SEMSCO and the REMSCO or REMACs or SEMAC would put out. And so you're setting the standard here. A region may choose to say, well, we want that standard plus, again, minimum standard plus something more. But it's the agency who would ultimately be the ones who would carry it out. Now, like Mike was saying, we have some regions who are already kind of doing this today. They have a credentialing process that they run for their agencies in the region for a variety of reasons, for whatever, and that could still occur in those particular cases. There'd be a standard credentialing process, and the agency essentially would develop, maybe it's an MOU or an agreement or whatever it is, for their region to run that process for them. And they would be able to carry that out kind of moving forward from there. So that's just a little bit more of that information to it. I think the other part that, Mike was talking about is, the region can then also establish those documents or processes in order to help the agencies so that every agency isn't trying to recreate the wheel in developing something or doing something. And again, I think many agencies would turn and say, well, if a region is willing to do this on my behalf, we'll operate through them because that just makes my life easier, or maybe it makes it easier for the providers who can turn and go to fill in the blank location on a given day versus just, at their agency. And so kind of moving it forward from there. So there's definitely some legal things and some things that would have to be worked out along this way. The working group would help to, kind of square that away and work to make it possible. And definitely, I think, would be a combination of what is needed from both an operational and a medical point of view, so physicians and agency leadership, in order to kind of, design it in such a way that it is functional and realistic for all those who are involved and would be affected by it going forward.
Thanks. I volunteer to work on that work group. I would also remind everyone that the New York State Bureau of EMS Trauma and Trauma Systems Policy Statement 1105 is still active today, which clearly defines REMAC's responsibility to credential New York State certified EMS providers. So I think it's been in practice for more than a decade and is currently being done in every region. It would be very important to make sure that we don't throw the baby out with the bathwater over some legal premise on a word such as credentialing. But I think it's critically important for regions to know who's in the system and to acclimatize them to the regional policies, which are different from region to region. EMS is very different in New York City than it is in Suffolk County, than it is in Susquehanna. And I think that's a very important point.
And I think that's some of the parts where you'll, again, the SEMSCO determines kind of that minimum of what credentialing looks like at the agency level, and then the region's determining, well, we want to make sure that everybody understands these additional 5 things or something along those lines. That's the part where that region would get involved in kind of those components and moving that forward as well. Absolutely.
Yeah, I agree with your concept, Mike, with both committees in setting it up. The concern is, agencies that won't, and that's what we ran into. So they're not familiar with the region, they're not familiar with the system, they're not familiar with the policies, and they say, no, this can't, we're not doing it. And that's where it became a problem. We do work with agencies that could do their own training, but at least they're getting the training. We're not calling credentialing. Remember, we had this argument. We were here for like an hour at the one meeting, de-credentialing, credentialing. But the point was, it's regional education and verification of who they are. You know what I'm saying? And the agencies like that. But if you go back to the agencies decide that they're in service, you know what I'm saying, then you're back to, in our region, 110 agencies, and they're not going to be regionally trained. You know what I'm saying? They think now, because of the policy statement, that they get credentialed or educated, and they're all doing it. And we have GMRs to hospital-based and everything. So I think if you keep that in there, not make it that it's agency-based, I think it should be lateral, that a region can't force that you take their training, that the agency can do it. But I think a regional standard is what we're talking about, that we want to keep in concept. Because, you know, I go in other regions, when I was in the system, I had to do one county, another county in New York City and Westchester, and the medicine was different. They didn't have capabilities. I mean, you know, up north in the rural area, they have one trauma hospital. So there is no policy on trauma. There's only one. You're either flying them or driving them. In other regions, providers have to know what the resources are, that they don't go to a level 3 when they're allowed to go to a level 2 or 1 within 30 minutes. You know, little things like that separate systems. And we just want to make sure that that stays. So I do support this. I just don't like the language when it always says agency, because then agencies, as we know, will do the bare minimum of what they need to do and not tied to the system. And that we have that working now where the agencies are tied to systems in regions, and we want to just keep that. But I understand the decredentialing and the financial burden, but I don't want to make it that an agency decides whether they're going to do it and how they're going to do it. And yeah, we got your sides, and they don't do it, as you know.
So I think there's,
I don't think there's any intention to undo the good things that exist. And then, you know, I think we all know also that the regions credential the medical directors. And so it'd be very easy to take away a medical director. So, you know, there's two sides to this.
so I think the other part to that one too is important, that, you know, again, it's setting a standard and it's moving forward. So there are some policies that are out there right now, and the problem is that there's not backing to them, so we're going to rescind them. And a lot of this and pushing and getting to these, you know, points of kind of where the end of the road is now we're at a point where those should be rescinded, because there is clear definition and guidance from legal that says they don't have a backing behind them in order to do it. We are working now on that pathway, and we now have multiple pathways to get there, which is nice. We can go through the REMAX and some of the statutes that's in there. We can also look at the agency system and performance standards in order to get there, and that's this working group that will be able to kind of move that forward. Who does that credentialing or how that happens? It may happen at an agency level. It may happen at a regional level if there's an MOU for that to happen or something else. But what you know, one of the things that you bring up is, well, what happens when an agency doesn't do it? Well, currently today, there's really not an action. An agency cannot do something, and, you know, there's nothing that can happen to it. There's nothing really that's enforceable. Once this goes into regulation and moves forward on that front, there's now an accountable action to make that happen, where the Bureau can go out and enforce. The Bureau can turn and issue an SOD or something along those lines for people who are non-compliant. One of the other components that came out, and I really just didn't get into it in too much detail, but I think that talks about one of the things that you just brought up, which is, you know, who's operating in a region. You know, there is, you know, a component of this language that talks about, you know, being able to review or things like that, that credentialing process. I think that would tell us what it is, and I think we need to flush that out a little bit to make sure that the regions are informed of who's credentialed by their agencies in their region. And I think, you know, those are one of the things that we'll not figure out, but I guess talk through and work through in that process, so that, you know, we understand the desire here is, you know, to make sure that those who are providing service in a region is, you know, that the region is aware of who's providing it there, and we'll work through that as well.
Yeah, and if we could just add that to regulation. I look back at a lot of policies, the bridge program. Well, one of the requirements of the bridge program from CC to Medic, you know what it is? Currently ALS credentialed in the region. So, you know what I'm saying? It's something we've been practicing for well over a decade, and then we're saying legally you can't do that. So that should be a good emergency reg, that credentialing is something that's real. And then the bodies can argue on what, you know, take it away and what have you. So thank you.
Credentialing is real. It's just a matter of who can credential. It's the agency's responsibility.
There's another option. We could ask that they amend Article 30 when we do the governor's budget recommendations, and they could add it to the section with REMAC where they're allowed to credential.
There is always recommendations and other things that you can do in different ways. Absolutely. Again, right now we're working with what we have, and I think you have legislation in there today that would help you get to where this is. And so it's just a matter of putting together a group, working through it, and, getting it done correctly.
Is the language, can you share the language of what the rule or what the decision was? Is that something that can be made public to this body? Just so it's more detailed and understanding, we can explain it to our regions and whatnot.
Sure, yeah, the language is, your motion has no standing.
Thank you. Thank you, Chairman.
So I'll appoint this group. I think, there are, I said this before, there are good examples of it out there. And, I think Mike's making a point as well that there are functional things that are working. We'll let this group come together. They're obviously not going to do anything without approval of this body. I think if they do a good job, then I will have them work on 0606. Any other discussion on this? So that was old business. Any other old business? I think new business, we already took care of the nominating committee. Is there any other new business?
Just a comment, Mike, if you don't mind.
Go ahead.
We're already here an hour and a half afterwards, so this is relevant. I'd like the executive committee to look at the scheduling of the council meetings. We've changed over the years since I've been here, and maybe it needs a relook. I mean, the Bureau does a great job of reporting, but sometimes it ends up being the same message a couple of times, and it's hard on them, and it's hard on, I'll see the same report. It's not really against the Bureau. I'm just saying the scheduling. Take a look at the scheduling, because we have long meetings like tonight and it goes long. And, I was going to order pizza. Don was already trying to find a place to deliver pizza tonight.
It's not as good up here.
But if the executive committee can look at the scheduling. Look at the scheduling if you could, Mike, and have the group, come up with a recommendation to maybe,
In what sense? I'm just asking, are we talking about changing the order of day one? You're talking about not having the three meetings on day
changing the
two?
order of scheduling. I mean, we changed from the old one to get the docs out earlier, what I'm saying? So we've had it changed. Maybe it's time to look at it again. Maybe,
I would say if you have a recommendation, or if anybody here has a recommendation, well, let me go with this one, just out of curiosity. And do people feel that this current schedule is the best schedule we've had recently, or does it need to be modified? I guess be the question. Because, Mike, I appreciate the feedback. Let's just figure out, A, is this widely that we want to change it? And if it is, I don't want recommendations today, but I'll gladly take them to Mike and I via an email. But I guess the first question is, do we like the way it is currently laid out? Committees all on one day, and then these three meetings on day two. Does anybody feel that this should change? Raise your hand if you feel we should readjust the schedule. Okay, so seems to be a halfway. So I guess if there's someone who has recommendations on it, and again, in the essence of time, I don't think it's something that, if it's okay, I'd like to leave it the same for this meeting to next meeting. But if there's recommendations for that one, maybe we set some time and work on
yeah,
that.
I'm not changing the dates or the times. The times and the days are good. Maybe the organization of the meetings and the timeframes of the meetings is just a point. My local REMSCO, if one committee has a long, body of work, they would have a longer time frame. If another committee doesn't have any work, then it would just be a short comment. They're scheduled an hour, no matter what the committee is. And
So we reduced it to 45 minutes. I don't know if you remember this or not on one of them. We reduced them all to 45 minutes, unless you told us something else. And then every meeting ran over. And we encourage anybody who doesn't have any stuff to tell us, and we'll cancel their meeting, good, bad, or indifferent. There's a lot of work being done right now, and no one came back saying, I have nothing to discuss. We also encourage everyone, and this would really help, is to have the in-between meetings. And we're seeing this in some cases, and we're not in others. If you have meetings in between, which is what we see of a lot of our other sister councils, then when you come to these meetings, a lot of the other discussions are already out there and done, and it's more a summary of what's going on rather than a full-on discussion while we're in person. And so I think, that's part of what we need to look at getting back to as well, is making sure that there's a WebEx meeting in between.
I was just going to say, one thing I would not suggest is competing meetings, meaning safety is meeting at the same time as legislative, which is meeting at the same time as somebody else.
And that's what we got away from. You know,
Exactly, yeah.
this is one of the dynamics, and it actually came up today in one of the sidebar conversations, was, well, do we go back to putting two things at once? Well, then what do people go to, right? I want to be here, but I want to be there. And so I am all for trying something different, if we feel there's a better way or something that will streamline it more. But, you know, I think we ended up here because of trying a number of different things.
No, and agree, and you got to get that out to the public because they're publicized meetings. I totally understand. I just asked that the executive committee look at, they all meet, they know what their committee's works are, and come up with, you know what I'm saying, maybe a little bit better schedule. We're an hour and a half past our normal time frame, and then we've had, you know, this happen a lot. But we also have short meetings. Training and ed this time was really short, and they didn't cover everything that was covered during the summer. And then, you know, committee. So just look at it. That's all my ask was, is to look at the scheduling, you know, to make it. We didn't have a lunch today. You know, yesterday was a short time frame. I remember you guys, as executive, have no time because you have your executive meeting at the dinner. So I would just ask that you look at the scheduling, you know, figure out if there's a, maybe optimize it. Keep the same time frames. That's already, you know, works. But maybe it's having one meeting on the Monday night. We have the program agencies. You know, maybe you could squeeze a meeting in there on the Monday night because most people are up here anyway, and shorten up the day on Wednesdays would be a recommendation.
Okay, we can do that.
So-
You know, the other thing that I tried to do this year is because so many people travel, we tried to keep the same schedule month to month, and especially because you don't necessarily see it until a couple days before. So people want to travel and set their travel plans well before, so we tried to keep the exact same committee schedule on Tuesday and the exact same meeting schedule here. And some things we can't control. You know, if the systems committee ties us up for hours, well, you know, that's Mark's fault.
And Mike, a lot of work has gone into optimizing this schedule. Ryan and Mark went over several years, put a lot of work into this. So I appreciate, you know, it needs to look at, but look, let's face it, the system, the CON stuff is a wild card, right? If we get that down and efficient, the schedule works. If we don't, we're at 4:30 and we got 1,000 things left to do, everyone's tired and we all want to get out of here. So I don't know that you're going to save a lot of time by moving around committee meetings again, or I think our goal should be to figure out how to process our work that comes out of the systems committee in as efficient, timely a way as possible, which clearly today we ran into some roadblocks.
And we have been already discussing ways that we could fix this system's problem so that it's more succinct and digestible by the folks here, so that we don't have to redigest it again from the systems meeting. So that's in discussion already.
Yeah, I just have one question from our SEMSCO in Suffolk. I know there was a new section 3032 added to Article 30 on the EMS task force, and they were just asking if there was any clarification of how that was going to work and what that entailed, because it really still needs to be developed.
Yep, we're working on developing, like I said, the framework on that one. The biggest thing that we're currently going to work on for 3032 is just those contracts to be in place. Once the contracts are in place for the basically paying for readiness and having ambulances around the state, then we'll move forward on kind of the bigger picture things of, you know, what other support can it provide when needed and specialized equipment or things of that nature. So I think you'll start to hear more about that in the next couple of months. But step one was, how do we get these ambulances in place? In part, as I, you know, look over at a commissioner from the West, you know, when we need something, we need something. And, you know, part of what came, you know, why that state EMS task force is being put in place is so that it's ready and able to activate when needed and on hours, not days. And so that step one is having those ambulances, probably around 50 of them, which would most likely be one from each agency, you know, in whatever those 50 are that are selected, so that when you go to activate, you're not taking a ton of resources from one resource, you know, from one area, or a ton of resources from one agency, you know, in order to move forward on those things. So definitely more to come.
Any other items? I will mention that I like to see dates well ahead of time, so all the dates for next year have been published. So if you didn't pick up one of the pink papers with next year's dates, we have the schedule for next year. There may be, between now and December 5th and 6th, an emergency meeting in order to pass the emergency regulations, so keep an eye out for that. We'll try to advise you of it as early as we can if we need to do that. We're really just waiting to see if we get those things turned back around to us so that we can push them forward. And aside from that, if that does
November
not
1st.
happen, we will see you on December 5th.
And just a reminder, documents for the next meeting will be due on November 1st. So please make sure to have them into Teresa by November 1st, agendas and documents.
So,
Motion to adjourn, Mr. Chairman.
Second.
thank you.